Good evening and welcome to the second edition of Sepsis Summit by ISW Council. I am Kamal Narayan, CEO of Integrated Health and Wellbeing Council, India's premier institution for health awareness, advocacy, and behavior change. As an institution that strives to make healthy and productive life for all a priority for everyone, this summit and this day, observed as World Sepsis Day, holds critical importance for us. And rightly so, as this is one condition that is the most preventable cause of death worldwide, affecting nearly 50 million and killing almost 11 million out of them annually. This means sepsis takes away a life every 2.8 seconds. It is only a bit less than deaths caused by heart diseases, but more than those caused by cancer. But unlike cancer, which frightens us all, many of us would have hardly heard about sepsis. Experts say more people are vulnerable to sepsis than to cancer or cardiovascular diseases, because it can be caused by many commonplace diseases such as dengue, malaria, urinary tract infections, or even diarrhea. Sepsis can affect older persons, pregnant women, newborns, patients in intensive care units through hospital-acquired infections, and people living with HIV/AIDS, liver cirrhosis, cancer, kidney diseases, and autoimmune diseases. It is a leading cause of death in newborns and women delivering a child. And not only this, most of the deaths caused during the ongoing COVID-19 pandemic too can be attributed to this dysregulated immune response of our body called sepsis. By now, you understand why it is crucial to stop sepsis and prevent all that causes this life-threatening condition. Unfortunately, the significant burden of sepsis cases and sepsis-related deaths worldwide come from low and middle-income countries, of which India is a part. And therefore, creating strong awareness and advocacy to protect lives from sepsis in India becomes the single-minded agenda of this summit. And to understand the India situation, how COVID impacts the risk of sepsis, and how sepsis management in India can be improved, we have a galaxy of experts and public health crusaders today with us for this second edition of Sepsis Summit, who will help us chart out an agenda for protecting more lives from this preventable cause. So let me welcome the esteemed speakers of this evening. We have Sri Love Verma, former Secretary, Health and Family Welfare, Government of India. Apart from his illustrious career as civil servant, spanning nearly 4 decades, Mr. Verma played a seminal role in the successful campaign for eradication of polio, introduction of free third-line treatment for HIV/AIDS patients, and the mainstreaming of accessibility issues for persons with disabilities in India. He also extensively worked towards improving health services delivery in India through finance planning, capacity building, strengthening infrastructure, and extensive coordination with multilateral agencies in the field of public health. We are also joined by Dr. Kishore Kumar, founder and chairman, Cloud9 Group of Hospitals. Dr. Kumar is a world-renowned neonatologist who has worked across North America, the UK, Asia, and Australia. After spending nearly 2 decades overseas, Dr. Kishore, along with 3 other founders, established Cloud9 Group of Hospitals in 2006. Through Cloud9, he has been determined to raise quality and service standards in maternal and neonatal care in India, a vision he has successfully achieved over the past decade. We are also joined by Professor Vivekanand Jha, Executive Director at the George Institute for Global Health, India, Professor Jha is also the chair of Global Kidney Health Faculty of Medicine, Imperial College of London, and the president of International Society of Nephrology. Professor Jha has wide-ranging research interests, including understanding of health and societal impact of kidney diseases around the world, and development of affordable, scalable, and sustainable primary and secondary prevention tools. He has worked with many organizations, including with WHO, to develop clinical practice guidelines and advocacy papers. Also joining in this session is Dr. Yatin Mehta, Chairman, Institute of Critical Care and Anesthesiology, Medanta, the Medicity, Gurgaon. Prior to this, Dr. Mehta was the Senior Consultant of Anesthesiology at Critical Care at Apollo Hospital, New Delhi, and Director of Department of Anesthesiology and Critical Care at Scott's Heart Institute and Research Center, New Delhi. He is a National Coordinator for Dr. Rosenthal International Nosocomial Infection Control Consortium and has many international publications in ICU sepsis. We are also joined by Dr. Kapil Zirpe. He is the head of the Department of Neurocritical Care at the Ruby Hall Clinic, Grant Medical Foundation in Pune. He is past president of the Indian Society of Critical Care Medicine, Council member of the Asia Pacific Association of Critical Care Medicine, president of the Association of Critical Care Societies in the SAARC region. Dr. Zirpe is the founding secretary of the Sepsis Forum of India. And we are joined by Dr. Anirban Home Chaudhary, professor and in charge ICU, GB Pant Institute of Postgraduate Medical Education and Research in New Delhi. Dr. Chaudhary is known for his contribution in the field of research on critical care and with both private as well as public departments. And last but not the least, Mr. Sanjeev Nawangul, Managing Director, CEO of Bharat's Serums and Vaccines Limited. Mr. Nawangul is among the prominent pharma leaders of India, and during his over 3 decades career in pharmaceutical and healthcare industry, he has served on the board of Johnson & Johnson India, Fulford India. He has also served as the Vice President of OPPI, Organization of Pharmaceutical Producers of India, and been a chairman of American Chamber of Commerce. So thank you so much, all our distinguished speakers, for joining this evening for a very important agenda, which was actually called to be the healthcare priority by WHO in 2017. And seeing the number of, the kind of burden of deaths it causes on the world, it is, I think, the most pertinent to discuss this topic, and especially on the day which is observed as a World Sepsis Awareness Day. So let me go to Professor Dr. Kishore Kumar and begin this summit today. Dr. Kumar, as I mentioned, that sepsis has also been a leading cause of deaths among the newborns and pregnant women, which we call maternal sepsis. So I would like to first request you to explain a bit about sepsis as a condition, so that our viewers, even the laymen, they can understand that what sepsis is all about and what is its relevance in protecting the health and lives of our newborn and pregnant women.
Thank you, Kamal, and thank you for the Health Council for arranging this discussion. And to start with, I can see your title, Decoding the Underreported Infection. I feel sepsis is overreported in India. The reason being very simple. If you look at just the newborns, because I'm a neonatologist, newborn specialist, 54% of the deaths are reported to be sepsis. So if the coding is correct and we have 54% of babies dying of sepsis, then that means we are worse than Africa. We know that we are not worse than Africa. So we have sepsis being overdiagnosed. We have innumerable case presentations, which we can talk about if there is a time permission. But one thing is for sure, sepsis is not a diagnosis. Sepsis is the pathway which leads to the uneventful or eventful situation. Sepsis is completely preventable, and it needs to be looked at what are the precipitating factors for sepsis. Sepsis is nothing but infection. In fact, if you look at the COVID preparations, most of the things which we are doing is to prevent getting infected. Whether wearing a mask, washing the hands, social distancing, we should have done all these for all the infectious diseases which we have in India. So if we follow this, we can virtually eliminate all the infections in India with the good hygiene. So sepsis is currently, as we look at the statistics, even if you look at the NFHS 5 data published by the Government of India in December 2020, we have a very, very high incidence of sepsis. That means too many things are being classified as sepsis. I'll just give you one example. Babies can present mimicking signs of sepsis because signs of sepsis or symptoms of sepsis is very non-specific. Babies can have a high heart rate, temperature instability, they can have breathing difficulties. All this can happen even with the metabolic conditions. When the metabolism is affected in a baby, that means if a baby cannot digest proteins, fats, or carbohydrates for whatever reasons, the toxins accumulate in the body and that can mimic sepsis. So everything which looks like sepsis is not sepsis. We need to identify what is causing the sepsis. Is it really sepsis? And then delineate. And I think all medical professionals, especially people working in intensive care, agree with me. A lot of diabetics come because their diabetes is not under control. And when their diabetes is not under control, sugar is a good food for the bacteria. So the bacteria colonizes and infects the diabetics. And that's why they get the infection. So the predisposing factor is diabetes, not infection there. So sepsis is overdiagnosed. We need to underdiagnose. We need to identify correctly the predisposing factor for sepsis and prevent. So prevention is better than cure. So that's where we should be focusing at. Back to you, Kamal.
Thank you so much, Professor Kishore. Interesting point. Though you are saying that around 54% babies dying is reported to be by sepsis. However, you are also highlighting that this may be overdiagnosis of this problem. However, while I'm of opinion, if I can have my opinion as well, is that the disease is not even, many of people would not be even knowing, but yes, at the healthcare system point of view, definitely, as you are mentioning. So let me go to Dr. Mehta on this. Dr. Mehta, is it a overdiagnosed problem or it is something that we are having many other causes which are leading to this, problem, which is becoming a ultimate pathway to, mortality?
No, it is certainly not overdiagnosed. In fact, the awareness is non-existent. Most of the common public does not even know what is sepsis, and they don't realize the importance. So many articles and so many TV programs you see about cancer and you see about heart attack. So you would think everybody is dying of either heart attack or dying of cancer. Nobody is even aware of sepsis. So I think we need to be, you have already given some statistics, which is quite worrying. And by 2015, Kamal, more patients will die because of sepsis than cancer or heart attacks. So it is going to be the biggest killer by 2015. Also, in developing countries like India, multi-drug resistance to antibiotics, that means the bacteria are not killed by any antibiotic which you use, is a rising problem because of gross misuse of antibiotics. So we will probably have a higher incidence and higher mortality. More patients will die in developing countries, including India, than what they were probably dying in the West or what they are dying, what they were dying earlier. So despite advances in medicine, tertiary care hospitals with advanced therapies available, still it has about 50-60% death rate when you get into severe sepsis and septic shock. That is when the blood pressure drops. So awareness needs to be increased. Early diagnosis is very important. And Unnecessary antibiotic therapy also should be avoided, which is grossly being done in India because we keep on pumping antibiotics to the patients. The general public starts taking it themselves, or the chemists start prescribing the antibiotic themselves. And now the Ayurvedic doctors also, we have the past health secretary sitting on this panel with us. The Ayurvedic doctors also can prescribe whatever medicines they want to. I mean, so this is going to increase if we are not put a stop to this. So we have to realize early diagnosis of sepsis, high degree of suspicion, patients go to doctors earlier and go to hospital for the appropriate therapy can save a lot of lives. There's so much of awareness regarding COVID in the last 1 year or so. So same awareness should be done for sepsis and prevention and treatment of sepsis and appropriate therapy. So we should be able to prevent a lot of disease, and we should be able to treat a lot of disease in appropriate time with correct antibiotics in order to reduce the mortality and morbidity.
Thank you so much, Dr.
I just wanted to clarify.
Sure.
Awareness is different from the death classification. See, if you look at the classification of deaths in India, we have 54% of children dying of sepsis. That means our incidence of sepsis is higher than Africa, which is worse than that. Awareness, I agree, there is absolutely no awareness in the general public. We need to spend time and quality education material to raise the awareness. But are we really having that high sepsis? Then we need to look at our problems. So I can show 1 or 2 case presentations. If time
I'll come to you, sir, Dr. Kishore, I'll come to you. But yeah, you are making your point, I think, quite impactfully. Let me go to Professor Jha. Professor Jha, this may be a case of overdiagnosis, as he's saying, because 54% of children dying because of sepsis, maybe, which is, apparently worse than African countries. We are worse than African countries in many other senses as well. So it may be a possibility also. At the same time, Dr. Mehta is talking about that there is an extreme lack of awareness for, condition like this. What is your opinion on this? Is it, do we really have this kind of burden of sepsis in our country where, and globally we see almost 11 million people dying annually, which is a much higher number of a cancer death, slightly lesser than cardiovascular. But Dr. Mehta is saying that, by 2050, it is going to be more than both the diseases. What is your opinion on this, Professor Jha?
Thanks, first of all, for inviting me, Kamal, to this panel with illustrious colleagues. So look, as we have realized during the COVID-19 pandemic, is that expressing one's opinions without backing them up with hard data can be hazardous. So I will refrain from doing so. But just to go back to basics, I would like to make a couple of distinctions. That we should distinguish infection from sepsis. So sepsis is not just infection. Sepsis is body's extreme response to infection. All infection can lead to sepsis, but not all infection will lead to sepsis. That's something which one should really also be mindful of. Some of this confusion can be resolved if we carefully think about what is sepsis, what is suspected sepsis, what is confirmed sepsis, and what really is not sepsis. So sepsis is suspected very frequently in India, and some of that suspicion may be unfounded. That's also something we should be mindful of. And as was mentioned both by Dr. Mehta and by Dr. Kishore, is that antibiotic use is indiscriminate and irrational, which has led to other problems also, which we can go to in at some other time. And because of the public conversation, this has led to entry of a kind of irrational fear of infection and fear of sepsis in the minds of people, which leads to this kind of disproportionate response of instituting antibiotics, instituting even the kind of antibiotics which should not be used in many settings, community settings, etc. So I think those are really very involved issues that need to be discussed more in scientific fora than in just public fora. But in the end, what we need are good reporting mechanisms. We don't have, unfortunately, very good reporting mechanisms. So that's why we are able to throw any kind of figure, depending on what source you want to pick. You can pretty much justify any figure that we can give. Of course, it can be overdiagnosed, it can be underdiagnosed, depending on the healthcare situation one finds oneself into. So in situations where the body's response to infection doesn't manifest itself, sepsis is underdiagnosed. For example, in neonates, where Dr. Kishore was, where Dr. Kishore has more experience than others, oftentimes the body doesn't respond appropriately. In immunosuppressed situations, for example, people who have kidney failure or people who have had organ transplants, often they're not able to mount a sepsis response. But we should also realize that sepsis syndrome can develop not just with bacterial infection, it can develop with other kinds of infections also. For example, with viral infections. The response that you see in COVID-19 is a sepsis syndrome, but that doesn't need to be treated with antibiotics. We have seen rampant overuse of antibiotics in that situation, which is unfortunate. Similarly, we see a sepsis response in malaria. We see a sepsis response in other types of tropical infections like scrub typhus, leptospirosis, but they don't need to be treated with antibiotics. So I think that is a kind of distinction that we need to make in clinical practice. So we need to be responsible, we need to respond in a rational manner, and we need to be appropriate, and we need to take a step back. It's quite appropriate to take with seriousness whenever a patient presents with fever, with a suspected infection, suspected sepsis. But we need to take the overall clinical picture into account and then develop an appropriate clinical response. But going back, I think it is the responsibility of the entire healthcare system to develop appropriate reporting mechanisms so that we are sure that we are talking of the same thing. We are comparing apples with apples, and we are not comparing apples with oranges when we are talking of sepsis, infection, or different terminologies in this context. So I'm going to stop here and we'll come back to these topics.
Thank you so much. Thank you so much, Professor Jha. I think very important point that there should not be a confusion that all infections are sepsis. Infections can lead to sepsis. This is what you are, very clearly highlighting. And I think let me go to Dr. Kapil on this, and then I'll come to Dr. Mr. Love Verma, to you also to understand the overall policy thing also. But let me try to understand from the healthcare professional first. Dr. Kapil, yes. All infections are not sepsis. It has to be distinct, very clearly understood. But infections can lead to sepsis, which becomes a pathway to death. And almost all kind of infections, something so commonplace like malaria or UTI, which is no more something which people really fret about. If are not treated on time, can lead to maybe some kind of this situation. So I would request you to give a little more detailed description of what kind of infections can lead to sepsis, and at what stage as a patient or somebody who is suffering from the problem should act and reach to the hospital without delaying, and should not also indulge in any kind of other treatments, maybe self-medications and all.
Yeah, good afternoon, and thanks for the inviting. And I was hearing Dr. Mehta, Dr. Kishore, Dr. Vivek, and everybody made it is very clear. Let me tell you, the sepsis is underreported. The reason is very simple. When we compare with the heart attack and the cancer, the symptoms are quite straightforward, easy to diagnose. Like heart attack, chest pain, EC shows sign, go with the angio, go ahead the angioplasty, thrombolysis. But what about the sepsis? Sepsis is not very clearly defined. It is very difficult for common people to understand he is in sepsis or her near dear one is sepsis. Like Dr. Jha pointed, a very important point. Every infection not necessarily should be sepsis, but sepsis is always the dysregulated human response or host response to the infection. So when you say sepsis, always there is the infection. But when you say infection, there is not necessarily it is a sepsis. So one need to understand every infection is not sepsis. When sepsis happens, there are no clear signs and symptoms. Like in immunocompromised patient, you will not get the fever most likely. You will not get the fever or the very classical signs of the symptoms. But in immunocompetent patient, you will get high-grade fever and this thing. But now, whether it is an infection or sepsis is a very thin line. What sepsis definition? Now that there is a definition, sepsis 3 definition is recently published and across the globe, we are following that. Whenever there is any organ involvement, suppose anybody has a fever, followed by he had a drowsy, he had a altermentation, he has a drop in urine output, or he is a breathless, or he has a hypotension. So there is a when there is a organ involvement with the infection, it is likely to be sepsis. Then he needs that. So unfortunately, there are no warranted signs or there is no clear-cut awareness about these signs, and that is delaying. If you see the statistics says that every hour delay in receiving the initial antibiotic or antiviral, you can landed with the increased mortality of 7.8% per hour. And that is what the COVID also giving us indication. That is what the other infection also giving us indication. So we need to work on, if we are talking about the public forum, we need to work on how to pick up the sepsis, how to pick up this patient is likely to be in a sepsis, how to reach to the nearby hospital. When you reach to the nearby hospital, whether this infection, okay, this is infection, this is sepsis, but not necessarily this is a bacterial sepsis. It might be viral, it might be parasite, it might be fungal. Because what Dr. Mehta said, viral infection, it doesn't require antibiotic. For fungal infection, it doesn't require antibiotic. For parasitic, it doesn't require antibiotic. So we have to work on everything. First thing, to differentiate in between the infection sepsis, then early signs of the sepsis, early hospital admissions and seeing your doctor, getting the early antibiotic if it is a bacterial infection or antiviral or antiparasitic as per this thing. So at every level we need to act. At every level we have to be alert. At every level we have to work in towards the reducing the delay in offering the treatment. And this is how you can reduce the mortality. Why sepsis is underdiagnosed? Because these are the factors which are affecting. And what Dr. Mehta says is absolute right. How we are coming up with the control mortality in the COVID because of the awareness. Everybody from the ill-treated people to the topmost officials in the government are talking only about the COVID and prevention. Why can't we follow this practice for every infection in future, whether it is a dengue, malaria, or rickettsia, or whether it is a bacterial infection, or it is any viral infection, or it is any fungal infection. So like that, we can control the situation. And if you see the early signs of sepsis, again, I am saying infection can present with some source like there is a wound on your diabetic foot, or suspecting the cough, breathlessness, you can suspect the pneumonia. But when there is an organ involvement, that altered level of augmentation or dropping urine output, or there is a jaundice you can observe from the outside, or there is a respiratory failure, this might be sepsis. See your doctor in hospital as early as possible.
Thank you, Dr. Jitpe. Dr. Anirban, what is your thought on it?
Yeah, I was listening to all the experts. See, whatever we say should be based on hard facts. So what do hard facts tell us? 2016 Indian Journal of Critical Care Medicine reported its first large extensive study in which it showed that 3 out of 10 persons admitted in the ICU had sepsis and 1 out of 3 such persons died. So that means it is a huge diagnosis. The number is too huge to call it an underdiagnosis. On the contrary, if you see look into the Annals of Internal Medicine published in 2014, the incidence has been found to be less than 12%. So the difference is made because it depends upon the place where we are picking up from. If we are picking up from the OPD or the community, obviously the total incidence will be less. If we are trying to pick up from the ICU, the incidence will be higher. The second, another important point which Dr. Kapil Zirke said was that organ dysfunction. To that, we want to add something. It has to be a life-threatening organ dysfunction. So when we talk about sepsis 3.0 definition, We believe life-threatening organ dysfunction, 1, due to infection, 2, and due to a dysregulated host response or immune response. So this is 3. And why all this confusion is arising out of us, because whether yes sepsis, no sepsis, because we fail to realize 2 important aspects, that whenever there is an there is an infection, there are 2 responses. One is an immune response and another is inflammatory response. And these 2 responses are not similar. Immune response is stored in the memory of the T cells. The body remembers. Body sends these messengers in the form of WBC, etc., to chemokines to fight it out in future episodes. But inflammation is not stored in the memory. So this inflammatory response and immune response are 2 distinct things, and on the basis of which the markers are released, a lot of things happen. And therefore, sepsis presents a unique situation by not being a disease, by presenting varying features, and by varying the spectrum from which picking up sepsis becomes an uphill task for the most astute clinician.
Thank you. Mr. Love, when I was reading about sepsis and from the non-medical point of view, what I could understand that an infection, when it's not treated on time, can lead to a situation which can also kill you ultimately. If I just pick up and we have seen, many such incidences during the COVID-19 time, I think, and that is what I spoke in my opening line also, that many of the deaths which were caused by COVID-19 ultimately were caused by, kind of a septic shock or cytokine storm, which, patient had to undergo. If I pick up the recent, case of what is happening in UP, especially, this Firozabad case, where around 12,000 cases have been diagnosed of or reported of dengue, which they call many times a mysterious fever as well. And out of that, around 114 children have already been reported dead. So, I believe these are those cases where an infection led to, I think, uncontrolled or undiagnosed situation, which led to a dysfunctional, immune response of the body, what is your opinion in terms of a government's response or health system response to such problem? How do you see as a policy maker, what has been your approach towards it, and how how do we consider it as an emergency in our healthcare system, and what kind of preparedness or response we have designed within it?
Well, first of all, thank you, Kamal, for organizing this very interesting symposium on the occasion of World Awareness of Sepsis Day. And I feel that some of the points which have been raised are so important that they need to be addressed by policymakers even now, because septicemia and sepsis, they have not been given the recognition which they deserve. And they're very much on the back burner. Nobody really talks about them. So we need to have SOPs. We need to have it flagged in the ICMR researches. We need to have it as part of the CME, which your council is doing a lot of. So I think at the moment it is not really too much of a priority. And in fact, what you have told me and what the others have also said is quite an eye-opener for me. And really, we need to take it up as a very important policy matter, which has been neglected so far.
Thank you so much, Mr. Verma. Mr. Navangul, do you really feel that, from the health system point of view also, there has to be an, kind of, I think, emergency response or some kind of well thought SOP protocols? Because I think the most important here is to how, and that is the point, word which is echoing in my mind, is that this is the most preventable cause of death. Now, something which is preventable, why can't we prevent it, and how so many lives are still lost globally. And in India, we also see almost the same thing happening. We see people dying of many such much more, I think, lesser riskier in that sense, infections which sometimes go out of hand or out of control, and you don't have kind of any response left to it. So what is your opinion? Where do we stand as a healthcare system? What role government can actually play in that, in terms of strengthening it in a manner that if I go back again to this is Firozabad situation which is still emerging there. Those kind of things can be stopped. And Dr. Mehta was talking about many other type of therapies also. There has been a action taken on a lot of those quacks, which the government call where the treatment was delayed or not right treatment could not reach to the patients, and that's why the ultimate fatality have happened. What's your opinion about enhancing the sepsis response mechanism in our health system?
Yeah. So thanks, Kamal, for inviting me. Let me try and come through a view from the industry and what we need to do from our side to help the health system. I think Dr. Mehta mentioned it quite rightly that we had a time when infectious disease used to kill a lot of people. Then we had better maybe vaccines and some other stuff, increased life expectancy. Then we have better chronic care management. Now we are again seeing that though chronic care management improvement has led to further life expectancy, we are now seeing infectious diseases again killing people. And therefore, what Dr. Mehta mentioned about 2050, saying that again, this sepsis might be a big killer, looks more rational in terms of at least a prognosis. But and Dr. Jha mentioned very well about the difference between trying to understand infections and sepsis, what leads to what. One of the things that we are seeing is that from our side in the last couple of years, COVID taught us one important thing from an industry point of view or from a research point of view, is that it's important to look at inflammatory modulators in a much better way, much more serious way. I think Dr. Chaudhary also mentioned about the inflammatory markers that are there and what do they do and play a role in management of sepsis. Management of infections and management of sepsis, we need to do, has to be understood a little separately because sepsis is kind of a body response more than just the infection. So as we are looking through that, we in the industry are now looking at all the inflammatory markers like TNF alpha or IL-1, IL-2, IL-6, all those markers, trying to see what really is it that we can do there to ensure that inflammation as base cause can be managed in a much better fashion for sepsis. That has been one of the most interesting kind of research we are trying to work through now. Because on one hand, we keep talking about antibiotic stewardship and managing antibiotics, and we do, there is at least some noise around that, but we still don't see enough noise around trying to see in sepsis management. There are many other things that you need to manage. Clinicians around are big experts, so they will tell you the challenges that they face. So we basically, from an industry point of view, are looking at that. And therefore, if we were to push policymakers, we would push them in trying to make a much better understanding of the fact that sepsis management has to be thought out very differently than just trying to club it under infection management and try to treat it like a part of infection management. I don't think that does service to this issue, and therefore in fact, if we start treating it a little differently, we might be able to give people much better guidance on how to manage these situations, because not many people are experts as good as what they are there in today's panel. If you look all over the country, and if you look at the admissions, and if you look at how sepsis pans out in ICUs, you really need much better guidance for people to manage this condition. So on one hand, it's about trying to look from an R&D perspective on the inflammatory markers, and on the other hand, I do believe that really sepsis management has to be taken out of this only infection management kind of look at it and treat it much differently.
Thank you so much, Mr. Nawal Gul. I think it's an important point, and I think that will address the challenge which other speakers also highlighted, that there has to be I think separate response to both these things, and one should not mix up both the situation, though they have a very strong interlinkages. Professor Kishore, let me come to the more specific side of the prevention of the children. So even if, let's say, you have highlighted at the very beginning that the numbers being reported are very high actually, and which has led to this I think assumption also, or maybe the conclusion that it is being over-reported. But having said that, deaths caused because of sepsis in newborn, I think, is a reality. The same is the problem with the pregnant women as well. Safe pregnancy is definitely one of the way to safe pregnancy, and safe deliveries are one of the major, I think, tools to prevent that. What is your point of view? How we can ensure that no lives, for that matter, is lost due to any kind of worsened infection which can lead to sepsis?
So Kamal, that's a very good question. See, the thing what you're talking about is sepsis awareness in the public. Sepsis awareness in the public is virtually negligible. That I can tell you. Only with the COVID, people started understanding the sepsis. Whereas sepsis as a cause of death is being over-reported, especially in children. And the reason being, if you look at the statistics of 2008 from the World Health Organization, which I projected just now, you can see definitely India is supposed to be showing 54% of neonatal deaths in the World Health Organization report as dying of sepsis. Now, acceptable deaths of newborns is only less than 2% as sepsis. In Cloud9 in the last 15 years, we have definitely shown that our causes of death of sepsis is 1%. Many a times, many hospitals can probably diagnose as sepsis. We screen all our babies for metabolic diseases. So many babies are dying of metabolic diseases which are misdiagnosed as sepsis. So similarly, I'm sure adults will have the same problem. So awareness is different from the classification of the death. So the two things, we need a three-pronged approach. One is primary prevention, secondary prevention, and education and awareness. So primary prevention, we are currently not doing at all. The secondary prevention, you definitely need to do that on a larger scale. Now, the third is awareness and education. Unless we do awareness and education for the whole public, sepsis remains enigma. Now, we in Indian Academy of Pediatrics have adopted a slogan for the last few years called AAA, which is avoid antibiotic abuse, because antibiotics are prescribed too much in India. Anybody can go to any pharmacy and buy antibiotics over the counter. It's not a OTC medicine. It is not over the counter medicine. So why are we allowing in government of India as over the counter medicine? So that's why we have a resistance problem. Any antibiotics nowadays, if a child gets typhoid, for example, most of the antibiotics which we used to in the past doesn't work. If you look at the culture of typhoid bacilli, 90% of the antibiotics which we have been using in the last 10 years is definitely not going to work nowadays. So we have a big problem of antibiotic abuse, lack of awareness, and overdiagnosis at death I'm talking about, not overdiagnosis or underdiagnosis in ICU. It's like when you work in a cardiology center, everybody looks like having a cardiac problem. When you work in a cancer institute, it looks like everybody is having cancer. So if you work in ICU, you feel everybody is having sepsis. So it needs to be taken in the context of the national thing. not just in particular any hospital. So clearly, in our case of Cloud9 hospitals in the last 15 years, our incidence of sepsis is less than 1%, clearly showing that we are doing something right. So awareness, primary and secondary prevention will go a long way to reduce the sepsis and classification. Thank you.
Thank you, Professor Dr. Kumar. I think that is quite an achievement which you have made. 1% deaths only having being reported for sepsis at least your in your establishment. But what is your estimation for because I'm sure the kind of healthcare is being provided by Cloud9, we can't expect the similar we know Indian healthcare is how heterogeneous it is, and what kind of healthcare is available in villages or in rural areas, and the number which is being reported by government to the even WHO may be an outcome of all those. What is your fair estimation of overall percentage of deaths being caused because of sepsis among children, newborns, and pregnant women or new mothers?
You asked me two questions, knowingly or unknowingly. I'll answer both the questions.
My questions can be mixed up because I'm not a healthcare professional. So you can kind of put them in a better perspective.
Yeah. No. One of the reasons we started Cloud9 was people were always saying this is unachievable in India. So I came back to India after being away in overseas for 20 years, and we showed that it's achievable. Now people are talking about this is not achievable in public sector, only private sector. So it's not true. If you put your mind to it, you can achieve it. That's number one. So it's easily achievable in the private sector. See, for example, in the US, there was a little bit of floods. The floods in the US, they talk about is even there is a 1 inch of rain on the road, they call it as floods. And already if you see Twitter, CDC has issued guidelines of how to avoid infection, how to take precautions of what water you should do, boiling the water should be done. We don't do any of this. Public education is zilch, zero. So why can't the government insist on all electronic and print media? Every day they have to advertise at least half an hour or 1 page of education about prevention of sepsis, prevention of infection, how to protect yourself from infection, hygiene, and you will make a huge difference. We're still talking about Swachh Bharat and everybody throws, and when 3 people throw it in the streets, definitely it's not going to cause anything for them, but somebody else will get the problems. So we have to address the primary prevention. We have to address the secondary prevention. Then only we'll move forward.
Certainly. Thank you so much, Dr. Kishore. Professor Jha, let me ask one question which can benefit to the audience also, related to your specialty. How many, what is the, because what we have seen that during the COVID-19 time also, a lot of cases, and almost, initially it was being reported around 20-30% as well, which actually lead to kidney damage or kidney, related complications. Normally, COVID considered as something which, damages somebody's lungs. Is it, and because of conditions like sepsis, or how many times actually, problems related to kidney infections or CKD or maybe urinary tract infections can lead to a situation which can, lead to the response like sepsis from our own immune system?
Thanks. So this is not about one specific organ system being involved. Sepsis is a systemic condition. So it means that it is present in all the organ systems of the body, and any organ system can be involved. Kidney is one such organ system. Its manifestation is picked up in the form of reduction in urine output and accumulation of certain waste substances which can be measured in blood tests. Similarly, liver can be affected, heart can be affected, and the cardiac pumping efficiency goes down. Brain can be affected. Hematological system can be affected. All the organ systems can be affected. That's the nature of sepsis, and so we have to recognize it as such. And on the other hand, we also know that if there is a pre-existing involvement of any or disease that has affected any organ, whether it is kidney disease, liver disease, etc., it impairs the body's ability to fight with any infection, right? And the sepsis syndrome gets dysregulated. So sepsis syndrome, let's recognize that sepsis syndrome is body's defense mechanism. And that defense mechanism is meant to protect the body. When that defense mechanism gets out of whack and gets dysregulated, that is when it becomes bad. So sepsis is not bad always. That's something which we have to recognize. And sepsis, what we need to do is that we need to give the body a chance to make use of the sepsis response that it is trying to generate to get it over the infection, whatever is the nature of the infection that has given rise to that syndrome. And we do know that in many circumstances, for example, in viral infections, etc., the body's natural sepsis response is enough for us to recover from that particular infection. In some bacterial infections also, recovery does take place even without the need for antibacterial therapies. So those are the kind of things that we should recognize. We should recognize that involvement of any organ system is a serious condition. And we need to, at that time, become serious about managing that infection appropriately. We need to provide support to that particular organ. In the case of kidney involvement, dialysis may be required, or other kind of kidney support might be required if appropriate, not in all situations. Similarly, other kind of organ support might be required for involvement of liver, cardiac system, etc. But do recognize that support for sepsis becomes necessary even earlier. For example, we need to appropriately manage fluids in these patients. So how do we give fluids? I think that's important. So it's not like when we start using heavy duty machinery and heavy technology, then only we are appropriately treating patients for sepsis. Treatment of sepsis starts really early. Treatment for sepsis starts by appropriate fluid management, by recognition of condition, by doing appropriate investigations, by also not starting wide spectrum or broad spectrum antibiotic unless they are appropriately required, and de-escalating antibiotics when culture report comes and when we do know that what is the organism that is causing the sepsis syndrome in a given individual. So there is a lot of steps to be taken. We do need to recognize that infection, especially, I'm not talking of sepsis syndrome now, in one individual in a given hospital ward or intensive care units has an impact on all the other patients also who are admitted in that particular healthcare setting, whether that specific ward or that specific intensive care unit is concerned. And the in charge of that ward or that intensive care unit will need to take appropriate remedial steps to make sure that other infections are, other patients are also protected. Healthcare workers are also often at risk from infections that sometimes might develop in those settings. So there are a number of things. Some of them are specific to individuals, others are specific to the wards. A few have even broader ramifications, and they all need to be taken into account.
Thank you so much, Professor Jha. Thank you. Dr. Mehta, Professor Jha said that the sepsis management has to start early, and it is not that only when somebody is rolled into an ICU and kind of those heavy duty or maybe sophisticated machines are used, then only you can respond to sepsis. If I would try to understand it from the layman point of view, is there any kind of a golden period also for either kind of preventing conditions like sepsis, or maybe reaching to a healthcare facility at a time where this sepsis response, which Professor Jha is saying that is not necessarily a bad response always. Body is trying to get out of the infection. And this response can also be utilized for, kind of expediting the cure process. What is your opinion on it? Is there any golden period, and what kind of efforts, if people can also start putting in, kind of their effort in kind of preventing this problem? Dr.
That's a very appropriate question, Kamal, and I would fully agree with Dr. Jha, because once the patient has come into the ICU and is already on organ support, the mortality goes up humongously. I mean, it has been shown by an INDICAP study, which has just been published in a large number of patients, about 9,500 patients all over India in multiple ICUs, that once the patient is in septic shock, the mortality is about 60%. We had also. So we don't want even if the patient has sepsis, we do not want it to degenerate to a level where we are not able to do too much for him. So it is important. There are two crucial instruments in the whole diagnosis and gamut of management. One is the emergency room of any hospital. Once the patient is arrived, the surviving sepsis guidelines initially have a 3R rule, 3R bundle. Some things which we're supposed to do in 3 hours time. That means send blood cultures, start appropriate antibiotic therapy, look at his serum lactate if it is going up, and give intravenous fluids to restore his blood pressure to normal. These were the things which needed to be done in 3 hours time. Now it has been reviewed to 1 hour, because as Kapil rightly said, every hour of delay increases the mortality by 7.8%. So you have to start the antibiotic therapy in time. That means that as soon as the patient comes into the emergency with suspected sepsis, the younger doctors or even the nurses or paramedics should be taught what are the things they should need to look for. That means have a high degree of suspicion and start these things which I have told you earlier. Procalcitonin is another bedside test which can easily be done, and it's a point of care instrument, small instrument, which can immediately, help you in diagnosing and maybe managing severe sepsis. Second is risk stratification. If a patient is in the ward, how do the nurses know? Because most of the times at night time, the doctors may not be sufficient in that particular institution. So the nurses should be able to dial. So we have something called a Q-SOFA, quick SOFA. SOFA score is sequential organ failure assessment. Quick SOFA, that is a little more complicated, that's meant for intensive care SOFA score. But Q-SOFA is very simple. The nurses, we have a code orange. The nurse looks at the patient's level of consciousness. Is the patient fully conscious or is not? She looks at the blood pressure. If the blood pressure is less than 100, systolic blood pressure. And third thing, respiratory rate, if it is more than 22. So if Q-SOFA has 2 points positive, the patient has a high degree of possibility of getting sepsis, and they should activate a code orange. That means escalate the problem to somebody senior who can intervene and say the patient needs to be shifted to the ICU or not. So this risk assessment, early diagnosis and risk assessment are very important. The primary movers in this would be the emergency doctors and the nurses. It requires very simple training. And I think that is where we should begin early diagnosis and appropriate therapy in time.
Certainly. Dr. Kapil, we have been talking about the, I think, overuse of antibiotics and the problem of AMR. And Professor Jha has also mentioned that we also need to make sure that, the wide spectrum or broad spectrum antibiotics are, not antibiotics in hospitals are used in I think, adequate, kind of correct, rightly, I think. What is your opinion? Because I think in India, we are also seeing that antibiotics, it is not only all, that one going to a chemist and buying over the counter antibiotic. Many times they are even being over-prescribed also. How to stop that? Because that is also becoming a major challenge, I think, in the long-term management of infections as well as situations like sepsis.
Yeah. It's a very good question, I will say, because see, first thing we need to understand, infection may be mild, moderate, severe. Sepsis is always severe. Sepsis is never mild. Sepsis is a life-threatening condition. So please, when you are using the word sepsis, that itself is a life-threatening condition that has to be managed in the appropriate ward or designated area. That is the first thing. Second thing, when we say about the antibiotic to prevent the higher mortality in a sepsis, we recommend the antibiotic within golden hour. But it doesn't mean that you should wait for the 1 hour. You have to start as early as possible, even 5 minutes and 10 minutes. Now, next question is the appropriate use of the antibiotic. 2012, Indian Society of Clinical Medicine did the Pan-India study, which is the INDICAP, to know the case pattern and what is the practice in India. And shocking observation from that INDICAP study, which was 120 ICUs participated with the 4,000 plus cases. You will surprised to believe 60% of the patients in ICU were prescribed antibiotic without any documented evidence of the infection. This is, I am talking about the ICU. So we need to first let down what is the scenario in an Indian setting. Then we have to train our doctors and our nurses and our healthcare system in the appropriate use of the antibiotic. Then not only this, when you are talking about the antibiotic, there is antibiotic stewardship coming to the picture. So on day one, when the antibiotics you are prescribing, it's an empirical antibiotic. It has to be the narrow spectrum as far as possible, has to be the minimum number, and as early as possible, you should withdraw the numbers, or you can even stop. And that period is after 72 hours when the cultures are available. Even you dare to stop the antibiotic. It is de-escalation doesn't mean that reducing the numbers or coming up with the less potent antibiotic. Even de-escalation means even stopping the antibiotic. So when you are talking about the antibiotic, it's a huge topic. It requires the antibiotic stewardship. It requires a lot of thought process behind when you are in an ICU. But the bottom line is, if you are suspecting the bacterial sepsis, as early as antibiotic might be within 5-10 minutes, don't wait for 1 hour. Appropriate antibiotic as per your overall clinical judgment, as well as the opinion, as well as the system involved and your experience and the feedback. Keep the minimum number of the antibiotic and as far as narrow spectrum, and as early as possible de-escalation. And de-escalation doesn't mean only reducing the numbers or this thing. You need to withdraw. If you work on that, yes, it is possible, but I think it's a huge challenge in front of healthcare in India. And to finish with, I will say that COVID taught us many things. COVID gave us a lot of mortality, but COVID taught us, why can't we have a task force for the sepsis? Why can't we have the audits? Why can't the audits are made compulsion for the every institute to prescribe what is their prescription pattern of the antibiotic, what is their utilization of the antibiotic, what is their resistance strain? Why can't they display their figures on the board? And this might give us some idea over the healthcare and that blown up problem of the sepsis across the country.
Thank you so much, Dr. Jilpe. Dr. Anirban, would you like to add, maybe half a minute maximum, because we would have to close this session, the speakers for the next session.
I fully agree with Dr. Jilpe also partly, and partly I don't. I also partly agree with what Dr. Jha has said, because Dr. Jha has said that this defense is protective. As long as it is protective, we mean it is regulated. When we talk about sepsis, it is dysregulated. So once it is dysregulated, it is no longer protective. Next, regarding what Dr. Jilpe has rightly pointed out, one, antibiotics are the mainstay of treatment in sepsis. We need to use the right antibiotic, we need to use them rightly, and we have to de-escalate. That is, stop the using after when they are no longer required or when they are no longer considered effective. So beyond that, whatever we do, like auditing and etc., these are essential. But a large part of that exercise is actually becoming an intellectual gymnastics rather than trying to percolate our entire decision-making system. So only one thing I want to add in half a minute is that currently we have a way forward, and in the way forward, it is the AI, the artificial intelligence. We all know that in AI, there are two systems. One is the convoluted neural network, another is the adult neural network, deep neural network. In the deep neural network, what we relate it with the statistically area under curve of ROC has been found to be 0.87, so close to 1, which means that if we apply AI based upon CDS, that is the clinical decision system, or the EMR, that is based on electronic medical records, we will be able to identify sepsis at least half an hour before. And if we are really successful, then our treatment, this is the way where actually we have to lead forward. We know that no law is above nature, natural law is supreme, but if we apply our scientific mind and apply our clinical skills, probably AI will be the only way to take us forward in this journey.
Thank you so much, Dr. Anirban. And thank you all our speakers in this first panel. Mr. Verma, we could not hear more from you, but at the same time, I'm sure the assurance which you have mentioned that you will be definitely taking this discussion more in your policy forums also. And we need to see that how our both private and as well as public healthcare system can have a better approach towards sepsis management, and otherwise also the overall infection management, not to confuse between the two, but at the same time, infections, we are exposed to a lot of infections in our day-to-day life, be it because of bacteria, viruses, fungus and whatnot. But and in this infection management, what is very important for all our audience to ensure is that we must not get into any kind of self-medication. The self-medication of antibiotics has already caused a massive damage, which is many times kind of making our healthcare practitioners helpless in terms of when these antibiotics are no more effective. So it is important to preserve them. It is important not to get into the self-medication. A lot of health, personal hygiene practices taught by COVID-19 to us, hand hygiene, masking, is also going to be a very, very, I think, helpful in terms of preventing many infections. So the most important way to prevent sepsis kind of life-threatening situation is to prevent the infections itself. So with this, I'm handing over this session to our next set of speakers who will be discussing more about sepsis and how we can prevent it. Thank you so much all our speakers for joining us today and helping us making more people aware about sepsis and also helping them to work towards preventing this. Thank you so much.
Thank you, Mr. Kamal, and thanks to all the speakers.
Thank you, Kamal.
Hello, Dr. Javeri, Dr. Ansari.
Yeah, hi.
Good evening, everyone.
Hi. So,
hello.
Thank you all. I hope we are ready to move to the next session, and it's a privilege for me.
Please.
Yes, please.
It's a privilege to be in this August gathering and to moderate this next session, which is about the reasons, risk, and recovering from sepsis and the pandemic, or amidst the pandemic, which is a very loaded subject because we all are going through a major, what is called a tsunami of cases of infections, which have been actually undone because of the viral sepsis we all are handling. With me today to take on this platform are four eminent panelists: Dr. Chandrashish Chakrabarti from Apollo, Kolkata; Dr. Yash Javeri, my dear friend from Regency Hospital, Lucknow; Dr. Sanjeet Sasidharan from Raheja, Mumbai, my dear friend; and Dr. Madhusudan Jaju from Care Hospital, Hyderabad. Dr. Jaju, are you there? He would be joining us in a short while. None of these distinguished panelists needs any introduction. Just to kind of add on, Dr. Yash Javeri has been instrumental in formulating the Indian Sepsis Forum, and as we all know, and a lot of us know, that there is a parallel session going on, a very wondrous academic feast going on about ISF Forum, which has included actually a lot of global thought changers into the field of sepsis. Dr. Sanjeev, an avid academician and a person with a great aptitude for research and a dear friend, He's there. He has always brilliant ideas. Dr. Madhusudan and Dr. Chakrabarti. All of you welcome. And I would thank ISW for providing this wonderful platform for all of us to come together and discuss the burning issues. So with this permission, I would actually want to open the floor. And I would request Dr. Yash to take the first part about how do we actually define sepsis in this new light of viral sepsis, where all our established understanding or concepts of classical bacterial sepsis have been thrown in wind. So how do you want to take this, Dr. Yash?
Thank you, Dr. Ansari. And at the onset, I'd like to thank ISW for this wonderful Sepsis Summit. Sepsis is traditionally and conventionally defined as organ dysfunction with an underlying immune dysfunction, new onset organ dysfunction. So if we say COVID also induces immune dysfunction. We all have understood it. And yes, it induces organ dysfunction. If it does not induce organ dysfunction, it might be just asymptomatic. Even if mild COVID is there, there will be organ dysfunction. So if we try to draw the analogy of sepsis to COVID, the inciting agent in sepsis is generally a bacterial agent, rarely a fungal or viral agent, whereas in COVID, it is always the virus. Organ dysfunction happens in both the disease. More severe the sepsis, more severe the COVID, more is the organ dysfunction. So there are many, many similarities, but yes, as you already pointed out, there are some differences also. Generally, COVID does not present as overwhelming sepsis or overwhelming hemodynamic compromise, but rarely it does so, especially in patients who have been compromised because of organ dysfunction or for some other cause. So there are many similarities in terms of etiopathogenesis. If we look at cascades or various cytokines and humoral cascades which are involved, they are also quite similar, but the inflammation often goes very, very overwhelming. If we compare an average sepsis patient and average COVID patient with ARDS, the inflammation might be much more severe in COVID ARDS compared to sepsis ARDS. So these are the intricate similarities and differences between both.
Thank you, Dr. Yash. Dr. Chandrashish, I would request you to kind of throw some light on the interaction between the host, the pathogen, and the environment as a determinant for the burden of sepsis. So how would you kind of look at that for our audience to kind of get a hang of what we are talking about, this lethal triad?
Right. First of all, thank you, Dr. Ansari and ISF for inviting me. So if we are talking about sepsis, and as Dr. Javeri already mentioned, that we are entering or we are trying to understand a new domain of sepsis, of which not much work has been done, that is viral sepsis. Viral sepsis is something where the patients, not only in COVID, but there are some other viruses like our classical dengue virus, which also presents with shock. And the principal problem in all these cases that we saw is basically there is some sort of a disruption of the endothelial integrity, the integrity of the endothelial cells. And as you know, the endothelial cells are kept together by certain cellular structures, the adhesin molecules, the tight junctions, etc. And by some mechanism, the viral sepsis or the virus itself causes disruption of this integrity, leading to increased vascular permeability, and therefore it leads to relative intravascular dehydration or volume insufficiency. We have all seen this in dengue for sure. In COVID, in some cases, we have definitely seen shock, but lungs are predominantly more commonly involved. So that is one. And the second is obviously the release of specific interleukins and TNFs, which causes vasodilatation. As you mentioned that in all cases of sepsis, whether it is viral or bacterial, we see a host response to the pathogen, and there are specific pathogen-associated molecular patterns to which the host cells, particularly the antigen-presenting cells and the dendritic cells, they interact with these PAMPs, and they start releasing the various inflammatory molecules like the interleukins and the TNFs. And these result in the immune cascade. And as we all know that the current definition of sepsis has definitely moved away a little bit from the systemic inflammatory response and gone into a dysregulated immune response and multi-organ failure. So that is based on the interaction between host and the on the pathogen, and also how the host body responds to the pathogen.
So, Dr. Chakraborty, at this point, I would kind of stop you and request Dr. Sanjeev to kind of pitch in. And how do you look at the three what is called the pillars of sustained dysregulated host response, Sanjeev? What do you feel? Is it the host which is primarily the playground where everything happens, or the pathogen which has the primary kind of responsibility, or it's a combined environment? How do you look at it, Sanjeev?
So, if you want to actually put it in perspective, when we look at severe and extremely severe kind of sepsis that we used to seeing in the ICU, we actually see the host who are having more comorbidities, who tend to fare more worse. But that's not what we're seeing in most of these COVID patients that come into the ICU. The hosts that are younger, who's got a robust immunity, is probably having more amount of problems as compared to those who are the elder ones. I think it's the response of the host that's making the big difference over here. If you look at sepsis per se as a definition, if you look at sepsis 3, it is just suspected infection plus Q SOFA plus SOFA. We can't really take this definition at all when looking at viral sepsis here. Viral sepsis is a completely different domain here, completely different domain. And we really don't know whether it's this particular virus that is causing the host to behave this way, or because we haven't seen this kind of response in any other virus till now.
So,
no.
Yeah, so Sanjeev, you have hit the nail on the head. I completely agree that the viral sepsis is something which is very difficult to really understand, and whether we are really talking about viral sepsis in the initial phases. But definitely there is a hyperinflammation response, and as you rightly said, in the younger people the burden is more, and predominantly I think it is an immune failure, which is probably the reason why this doesn't come into the classical florid inflammation like it comes tiptoed from the back door entry, comes inside and loots you and strips you. So that may be one way. Dr. Yash, at this point of time, I would want you to throw some light on the essential differences between our well understood bacterial pathology. Even to some extent fungal sepsis is very, very predictable, but why viral sepsis, when we talk about, we start kind of thinking whether it is really sepsis or inflammation or failure to control, till a secondary superadded infection precedes and changes the whole kind of environment.
Yeah, what I understood after reading about COVID, every individual is different, immune response is different, and there are multiple host factors which we were rightly talking about. So it is the interaction between the immune dysfunction, the inciting agent, and the host factors which ultimately decides the outcome, which is the basis of this damage response framework, which is highlighted for COVID. What it says, if you have a mild and just adequate response to the viral infection, you will be asymptomatic or in the mild category. However, if in this category 1, your immune response starts overwhelming, you can land up into category 4, which is a critical illness. If the immune system overwhelms the infection beyond a limit, the organ dysfunction ensues. If it is just adequate, now how this immune response has to be just adequate, it's very difficult, and there are many factors which ultimately decides on the adequacy of immune dysfunction. What we desire is an immune response which is just adequate, localized at the site of infection, and self-control. But what happens in critical illness and sepsis and critical COVID? It becomes self-augmentative and self-destructive. That becomes a problem. It becomes self-sustained, and it causes organ dysfunction because of various cytokines. So this
thank
is
you,
the
Dr.
major
Yash. I will move on to Dr. Chandrashish. Dr. Chakrabarty, what do you feel? What is the point where you find a person with severe COVID most vulnerable for secondary infections? When do you really, in your practice, do you feel that, okay, fine, he came with bad COVID, but you did something to improve the oxygenation or looked at the thromboinflammation? But do you think it is a distinct entity from a sepsis till a secondary infection comes in, or it is just a kind of sepsis which is playing in a different format? I'm sorry, I'm being repetitive because there is something which we have probably missed in the understanding of a true viral sepsis.
Right. So, I will. I wish I had a very one-line answer for your question, but unfortunately, I don't. So I'll try to express whatever I think. So in COVID-2 particularly, which has been the most devastating of the waves that we have seen, most of the time the patient obviously presented with respiratory symptoms, and they were real. Most of them did not have much of leukocytosis, much of hemodynamic instability that we have seen, at least in our center. There has been considerable, a good amount of data from Europe. Unfortunately, in Indian data, we have got some publications, but not very, not put together. But from the data that we have from Europe and UK has found certain distinct differences from other kinds of hospital admissions. And the incidence of ventilator-associated pneumonia in COVID patients from secondary bacterial infection is much, much higher than we expect from other kinds of admissions. For let's say the patient is intubated for a COPD exacerbation, and the secondary VAP incidence is much higher in COVID. That has been reported and has been well documented and published. Secondly, we have seen that if you go by the principles of antibiotic stewardship, most of the time we will not expect very multi-drug resistant infections to happen to these patients because they were not exposed to antibiotics previously most of the time. Since they came to the hospital, at least in our hospital, we don't give them very high-end antibiotics. But when they are growing infections, they are resistant infections. They are growing a lot of enterococcus in blood, which we have seen. And it's very difficult to make a timeline that they will start getting worse after 5 days or 7 days of ventilation or 10 days of ventilation. But by 1 week in the hospital, if they are very sick and on ventilators, the incidence of ventilator-associated pneumonia that we have seen and the incidence of bloodstream infection that we have seen is significantly higher than the same corresponding group of patients in the same hospital in the non-COVID wing. Why is this happening? Is it because of the immunomodulators that we are giving, which include steroids and other kinds of immunomodulators like the tocilizumabs and the JAK inhibitors? I don't know. Maybe a possibility. But then if you look at this publication by Manu Shankar Hari from UK, and he has shown that patients who have received steroids in the large cohort of patients in UK, they did not have a significantly higher incidence of hospital-acquired infection. So he has said that the steroids did not play a role in increasing the risk of infection in these patients. However, in India, in many centers, people have not stuck to the same principles of 6 milligrams of dexamethasone for 10 days and stop. Many patients have got much higher doses of steroids. Many patients have got pulse doses of steroids depending upon physician discretion. And whether that has contributed, we don't know. So I really don't have a very clear answer to your question that after so many days, whether there will be a secondary bacterial infection which will start kicking in. But I definitely know that the incidence of secondary bacterial infection is much higher than the corresponding same kind of population in non-COVID unit.
So I'll thank you for that, Dr. Chakrabarty. It was very encouraging to know that we are looking at it, probably steroid as one of the contributors to secondary sepsis is a possibility, but unfortunately we don't have standardized usage of steroids in our country, and a lot of people have been using variously. But I'd ask Dr. Sanjeet and followed by Dr. Yash one single question. In classical sepsis, we say delta SOFA is a very important indicator for worsening sepsis. But we have seen in COVID specifically a single organ being so badly involved for such a long time with a reasonably well preserved other organs. And that is something which is so counterintuitive, and it is very difficult to keep on calling it a sepsis for the first 7-8 days, where there is intractable hypoxemia, whether you are trying invasive or non-invasive ventilation. And there probably you are desperately using immunomodulators, whether it is virus, which is like a cold sepsis, hitting you, eating at your lung, finishing your oxygen carrying mechanism, and then preventing you, then posing you as expected any kind of nosocomial infection because of the stay in a hospital, and then absolute inability to fight the secondary or second hit. Sanjeet, your thought, and then Yash, I would want a quick take on that.
Yeah, so absolutely, what you said is spot on in my mind too. I mean, there was a series that came in from United States. Almost 30% of them had liver injury. Some of them had depressed immune response. Now, I think this depression of immune response is the most important thing that comes in. A hyperinflammation followed by an immune paralysis. And this immune paralysis probably is because of the huge hypoxia load that the particular virus is inducing, because it predominantly affects the lung. So that is the reason that this hypoxia probably are flogging that mitochondria in such a way that by the end of 7 or 8 days, I don't know the exact time, but that's when we probably start getting secondary infection, because we see mostly in the second week that patients of this nature, of course, it also corresponds to the time that we're giving dexamethasone. But let's take it. Dexamethasone that we're giving is such a small dose that it should really not cause the kind of secondary infection in at least in our settings where we're using it very judiciously. So I completely think that this is probably related to the fact that we have a hyperinflammation. The mitochondria are working very, very hard, at the same time getting less oxygen, and immune paralysis, which then exposes this patient to this kind of bout of secondary infection.
Your take, Dr. Yash,
Yeah.
something that you look at,
Yeah,
how do you look at it?
It's a very novel question actually. While we studied about fungal sepsis also initially, many a times, not always, we had a low indolent course also for fungal infection. The reason why we could understand is because there is lesser release of endotoxins. If we compare to bacterial infection, it could be lesser. But we understand endotoxins are not only released from bacteria, they can be released from the gut as well. So that theory is also questionable for viral infection. As Dr. Sanjeet and you already highlighted, pulmonary predilection, pulmonary endothelitis is what bothers the patient and us most. Whether the ACE inhibitor, which are more in the lungs, is the main cause or there is some other cause, it still remains a dilemma. But it's a novel disease, so we are still learning about it. No clear answers on this.
I completely agree, Dr. Yash, that we have more questions than answers today. Moving on, Dr. Chandrashish, by the way, is Dr. Madhusudan Jaju here with us? I can't see him. Okay, fine. So, Dr. Chakrabarty, over to you now. So, moving on, what is your what is called a look towards a syndromic approach versus the pathogen-based approach, and community versus nosocomial infections? I'm just taking a step back. We are moving out of the COVID arena. I'm just going back to the global sepsis burden. What do you look at that? Whenever your RMO or your registrar or your JC calls up saying that, sir, this looks like sepsis, what thoughts comes to your mind first? That, okay, fine, are you going back to look for what is a syndromic approach, or what is the organism, or together everything? Because we need to kind of thrash it out for our audience. What exactly is in the mind of an intensivist? When you hear the first call of sepsis, there are people who want sepsis codes, actually, like RRT and your PERT scores. per teams, you should have probably sepsis teams. So what is your thought on that, Dr. Chakrabarty?
Thank you for that question. That question is a very loaded question, actually, because this is something that we get calls every day. Because somebody gets shifted from the ward saying that this patient looks septic and therefore has been shifted. Now, unfortunately, sepsis has been a little bit of a dumb diagnosis in many cases. When you don't understand much, you say that the patient is septic, which is unfortunate. On the other hand, we have missed a lot of sepsis because we have really not paid close attention to the QSOFAs and other things. So there are two sides of the coin. Now, if I hear the word sepsis, definitely I want to know whether the patient has got admitted from the emergency. That is it a community-acquired sepsis? If it is community-acquired, I definitely try to understand two things. That is, do I know or can I guess from my clinical examination and history what is the organ which is involved? For example, if somebody is coming to me after staying at home with a Foley catheter because of some sort of a prostate cancer, with shock, I will definitely think urosepsis first. If somebody is coming with shortness of breath and fever with shock, I will think about pneumonia first. But there are situations where I will not be able to, or my resident will not be able to pinpoint at the organ of insult. And in those cases, at least in India and in our country, we should definitely think about tropical sepsis and tropical infections, where pointing out at a particular organ becomes difficult, and that is something which we have to rule out because we live in that part of the world. So that is second. So this is about community. As far as patients who are being shifted from the hospital and other parts of the hospital, or sometimes from another hospital through the ER, we are definitely looking at a much poor scenario of hospital-acquired sepsis. And then many times it becomes very difficult to understand the source because the patient may be on a ventilator, shifted from another hospital, having lines, etc. So we definitely send pan cultures and try to cover for multi-drug resistant bacterial infections as well as fungal infections, and then go by the microbiologists. So that is how I take. The other thing that I have to decide is whether the patient who is coming to me with sepsis, or at least quote unquote sepsis, whether I can resuscitate this patient and along standard guidelines or not. That means, is this patient who can take in fluid without much of a problem, or is it a patient who is, say, undergoes dialysis or has got a heart failure, etc., and I need to do a better judgment and step away from standard sepsis guidelines.
So, Dr. Sanjeev, at this point of time, as Dr. Chakrabarty very clearly said, that we have to think about everything which is happening around the patient, whether he has a host factor, whether the pathogen, organ specific, and we have very beautiful surviving sepsis guidelines which keep on getting updated. But I would want to ask or digress a little bit, asking that where does personalized sepsis care comes in? Where do you really think there is a personalization of care for these severe septic patients? If we have the same guideline that we apply for everyone, do you think in that we do make mistakes and sometimes overtreat, or sometimes we are not able to really look into the mechanistic approach of that and deliver the right care? So just your thought from your experience background.
Yeah. So personalized medicine is the key in every field of critical care that we are dealing with. Let it be sepsis, let it be nutrition, let it be any field that we know about. So similarly, if the biggest fallout of this guideline-based therapy has been the excessive use of antibiotics in the first 1 hour, causing this huge amount of antimicrobial resistance pattern that we're seeing, and the usual drying up of the pipeline of antibiotics. And the second approach that we see, which is guideline based, which has been causing a lot of problem, is the 30 ml per kilogram of fluid management. Both of them can be extremely disastrous for mankind. For that matter, I'm worried if my child would have a next small cut on his knee, I would be worried which kind of antibiotic to give him because of the resistance pattern, and I'm worried about my resident at the following that 30 ml per kilogram in a patient who's been huffing and puffing fluid in his lungs. So yes, personalized medicine is the key, and syndromic approach is the way to go, so that we can actually go to a target while during management.
So, Dr. Yash, coming to you, a more different question. How do you balance your antibiotic initiation in your ICU? Are you still, allowing your, residents to, kind of give it first, hit hard, and then we will think, or think first, or look at the clinical situation and keep applying your mind? So, difficult, but how do you kind of handle that?
Yeah. See, we try to avoid the knee-jerk reactions for antibiotics, and yes, definitely we do not allow the residents, senior residents or fellows. Yes, they are equipped and they are knowledgeable to prescribe antibiotics. We take into account many things, as everyone does: antibiotic history, exposure to healthcare, previous admissions, any previous culture reports, what antibiotic the patient has been on, organ dysfunction, site of infection. So there are multiple factors, and we were in a habit to stratify. You have to risk stratify each and every patient. If we have to individualize therapy, we have to start individualization with antimicrobials. So whatever antimicrobial you use, you should have a justification for your correct usage. So we have forms where we fill if the risk factors are there for MDR gram negative and you are using a higher end antibiotic, then you have been justified and documented the cause. So we look at multiple entities and not only on single. We also incorporate procalcitonin at times, especially when the diagnosis is uncertain, or if we want to avoid antibiotic like carbapenem vis-a-vis BLI, we often resort to procalcitonin levels also to guide us. So these are various factors which we try to incorporate into our practice, and we try to avoid a knee-jerk reaction or drop of hat reaction. Generally, 4 of our consultants, we discuss amongst ourselves even for smallest change, and if there is a doubt, we again revisit the decision. This is how we do it.
Thank you, Dr. Yash. I think that's very candid, because we all don't have really answers in the beginning. At the same time, you don't want to, for a very unstable patient, really be very questioning, and you need to really initiate the therapy early. But the whole question is to coming back and asking ourselves, what are we trying to achieve, and how can we narrow it down, and some kind of structured approach towards the usage of empiric usage of antibiotic would be definitely worthwhile.
Ansari, just a small note on this. This each hour's delay in initiating antibiotics cost lives. It is probably attained quasi-religious status. This is what has occurred, and I think the only 2 places where we probably need to do that is neutropenic sepsis and probably real septic shock. Otherwise, it's given for every patient in sepsis or not sepsis receives the antibiotic. I think that's the problem that is coming.
Yeah.
So I completely agree, but at the same time, Sanjeev, and this forum, I don't think we should be kind of giving this information, especially the ones who are coming in, that okay, fine, you can take time. I don't think so. I would not say that. I think, yes, please go ahead.
I have one point. See, when we are resource limited, when your manpower is not that well equipped knowledge-wise to decide on any therapy, then guidelines are good to start, good to follow. But guidelines should always be contextual to you. Have to look at your facility, your manpower, your patient, his pocket. So initially, when you don't have trained manpower, guidelines-based care can probably overall improve outcomes. But if you have trained manpower who knows their subject, who knows the hemodynamics, probably then you have to have personalized medicine, as we follow in most of our ICUs.
No, I completely agree. Now, quickly moving on to a little core subject, Dr. Chakrabarti, in your institution, everybody is actually going through their own institutional antibiograms, epidemiology. What are your top 3 organisms of concern? I will not say variants of concern. I'll ask you the organisms of your concern.
You mean organisms of concern for hospital-acquired infections?
Yeah, whichever way. I'll talk about that. You can even go back and talk about community-based organism if you want, but mostly nosocomial organisms in your ICU, which are worried. I'm not going into syndromes, but I'm asking about what major organisms you encounter with, and what thought comes to you. Okay.
Yeah, I think the most important organism which we fight not only in my hospital, but as far as I know, most of the hospitals in India is Klebsiella. In some hospitals, it is Acinetobacter, but most of hospitals it is Klebsiella. 2 and 3 you can choose. If you make Klebsiella 1, 2 can be Acinetobacter, third can be maybe Pseudomonas or E. coli. Gram positives are not much of a problem, except I told you in COVID we found a spot of Enterococcus, maybe because of various reasons. We can discuss that, but not always a problem. But yes, this will be mostly most of the concerns. And sometimes when you have outbreaks of Candida, particularly Oris, that's a concern. But as you know, Oris comes in crops, it comes in outbreaks and then goes away. Fortunately, as of now, we don't have much, but sometimes when it comes in crops, that's definitely a very big concern.
So on that note, a quick follow-up question, and that I will take it to everyone. If you say Klebsiella, now the important question, what percentage of your institutional Klebsiella, now we are only talking about nosocomial infection, knowing that they are coming in breakthrough either from the respiratory secretions, and you are pretty sure that it is clinically relevant. That means your CPI score is high and you are worried in the tracheal secretion there is Klebsiella. So part one, what is your carbapenem sensitivity in that? And number two, what is your empiric go-to combination antimicrobial at this point of time? If you have a second hit sepsis with hemodynamic instability in an immunocompromised patient just like COVID, and you are suspecting a bad respiratory infection or hospital-acquired infection of the respiratory tract with Klebsiella.
I'll start first then.
Yeah.
See, any hospital-acquired infection, especially in ICU, most of the time the attributing agent will be a gram-negative bug, and we have carbapenem resistance of the tune of 60 to 70% in hospital-acquired gram-negative infections. So generally, what is our go-to combination is either carbapenem plus colistin-based combination, or it could be BL-BLI plus colistin-based at occasions. But most of the times we have to use a colistin-based combination for all such hospital-acquired infection, more so for pneumonias. This is my routine practice. So if we have a nosocomial pneumonia, colistin will be added automatically, generally with carbapenem. At times it could be with some other agent.
Sanjeev, any take add-ons?
Yeah, so 70% of my Klebsiella are kind of carbapenem resistant. So I can't look at carbapenems at all. And out of that 70%, almost 90% are combined NDM and OXA48. So this is what I'm getting in Klebsiella. And so the go-to antibiotic for me, empirical also, is ceftazidime avibactam plus aztreonam if it's concerning the lung infection, and nothing else but that when I'm doing for Klebsiella. Whereas E. coli has got something very different. E. coli is more of NDMs. So since there is more of NDMs than E. coli, I can very well do with just aztreonam. Colistin I'm kind of not using much concerning, because I got this ceftazidime avibactam and aztreonam in my armamentarium as of now.
So two questions over here. Before I'll just have a quick take from Dr. Chakrabarty. He didn't speak about the antibiotic choices. But coming back, when you said NDM, so having a pure NDM growth, and even then if you want to add aztreonam, you are worried about the efficacy of that single drug. So you will always have a combination. Taking from Dr. Yash, what he said, that he will have a polymyxin-based strategy. Fair enough, only for a urinary tract, you will have a colistin definitely mandatory on board. Otherwise, polymyxin B or polymyxin E, depending on your choice. But as you said, that you will have to definitely think beyond carbapenem. And if you are using carbapenem, definitely a combination therapy. So quickly, Dr. Chakrabarty, what is your practice at this point of time?
Right. So I think we are concentrating on pneumonia as far as I understood, because the antibiotics will be very different for various other sources. So antibiotic for pneumonia, if the patient is in shock, in septic shock from pneumonia, hospital-acquired or nosocomial pneumonia, I will add colistin or polymyxin B, actually polymyxin B. And with that, I usually don't add carbapenems nowadays, because as Dr. Sanjit also mentioned, that our sensitivity for carbapenem is 30%, around 30%. So it doesn't make much sense, number one. Number two, even if they're resistant, the MIC is much higher, above 8. So again, I will not be able to achieve that concentration even if I give high doses. So difficult. Sometimes I add high dose of minocycline, because we have got a good sensitivity against Acinetobacter, and sometimes sometimes Klebsiella as well. As far as Cazavi is concerned, ceftazidime avibactam, Klebsiella, which are OXA48, they respond wonderfully to Cazavi. But again, we have 30 to 35% of our Klebsiella which are OXA48, and most of them are unfortunately NDA. So either we have to add aztreonam to it, or we have to give colistin. Obviously, we cannot know that before the whole thing comes back, and that takes 2 to 3 days time. Now, I just want to mention it here because many people are using Cazavi with aztreonam, that if you are using Cazavi with aztreonam, we have to give both the drugs together. The timing of the drug should be together, and they should be given 8 hourly. That is 2.5 plus 2 grams of aztreonam, 8 hourly, has to be given as an infusion. It cannot have a different timing in the medication chart. That doesn't work. So that is something which is, I think, a very important message we should go, because I have seen many of my resident registrars use it wrongly. So that's why, at least for students who are listening to this, if any, I hope there are some, it should be something that should be kept in mind. They should be given together.
Thank you, Dr. Chakrabarty. Yeah, thank you. Moving on, Dr. Yash, now, I think we will quickly touch
I just wanted to mention something. I think Dr. Madhusudan has joined, so if you can please incorporate him.
Yeah, hi, Dr. Madhusudan. Can you please, I can't see you. Dr. Madhusudan, are you there? Yeah, hi. Hi, Dr. Madhusudan. Welcome.
Thank you.
Thank you. So I think we have had a pretty fruitful discussion on the reasons and the risk, and now we are moving towards the recovery from sepsis. But one question: what is normally the kind of infection burden in your ICU, especially if you talk about Klebsiella, Pseudomonas, which are carbapenem resistant ones, and what are your empiric antibiotics usage for these kind of pathogens?
Yes, good evening to everyone, and thanks Yash and other people for giving opportunity. I think sorry for something was joined late in between. The most common infections in our ICU is because of the COVID. A lot of people being a tertiary care center, a lot of patients we get referred from the outside hospital with using some of the other medications for them. And we find out most of the infections are gram negative. The topmost will be, the first will be the Klebsiella pneumoniae, second will be the Acinetobacter, third will be Pseudomonas, and fourth will be E. coli. The common trend what we are seeing in our ICUs. And whenever these people are there, we try to send out the carbar test and find out which type of mechanism of resistance is there, and on that basis we choose the antibiotic. I think most of the other people finalists were discussing, most common will be the polymyxin best combinations will be there for starting empirically, and after getting the carbar test we streamline or de-escalate or readjust the doses of antibiotics according to the carbar test what we get it.
Thank you, Dr. Jaju. That was very helpful. And now we're moving on to the second part for the recovery portion now. So, Dr. Sanjeev, what is chronic critical illness? Is it a term, or is it a term of desperation, frustration? What do you feel? What is chronic? It has been defined well, but still, what is your take on that?
So I would probably put it as a persistent inflammation, immunosuppressed catabolic syndrome. This is what chronic critical illness is probably, and this is, we are seeing it so often now in COVID, and in fact it has to be recurrent as persistent inflammation, immunosuppression, catabolic syndrome, PICS. This is what it is. And these patients are catabolic. I'm actually studying the VOD of these patients, and we're seeing them to be catabolic for almost 6 months after getting into this. And when I did testosterone levels and things like that and growth hormone, everything is suppressed. So there is this particular phase, and we probably, as Dr. Paul Wishmeyer puts it, we aren't creating survivors, we're probably going into victims.
Absolutely.
So, Dr. Yash, what is your take on that? And in the same breath, if you can also throw some light on cytokine activation syndrome. So, at one there is a peak and there is a valley. So, where do you look at that?
I will like to congratulate Dr. Sanjit. He has put the previous statement in very right perspective. Chronic inflammation and catabolism is what defines most of the critical care survivors, rightly called survivors. Our understanding about long-term sequel of critical care was probably much poorer pre-COVID, and COVID has made us understand what does post-intensive care syndrome actually mean, because we have so many patients with indolent inflammation, recurrent events, respiratory events, MI. So inflammation persists. In fact, most of the critical illness also some degree of inflammation persists, but the magnitude of disease is small, so those illnesses often go unrecognized. So even after discharge from ICU, the suffering and the new journey starts from there, and they need a multidisciplinary team approach for their rehabilitation, especially the rehab physicians, the dietitians. They have a bigger role to play. Going on to the next part of the question is cytokine activation syndrome. What happens in any severe illness? There is inflammation. Inflammation basically defines most of the cascades, whether it's a bleed, whether it's a head injury, whether it's burn. So inflammation generally has two phases: the initial phase of SIRS, severe inflammatory response syndrome, which is a pro-inflammatory cascade largely, followed by a phase of CARS, which is compensatory anti-inflammatory response phase. What do we want? We neither want SIRS phase, we do not want CARS phase. Initial thought was SIRS is what caused major morbidity and mortality because of cytokine cascade and organ dysfunction. But we have understood this CARS phase cause more of morbidity, more of secondary infections, and probably more of deaths also because of second hit infections. So neither we want this SIRS phase nor we want this CARS phase. We want immunohomeostasis. The aim of critical care is achieving homeostasis. And if immune dysfunction is central to pathogenesis, as in sepsis or COVID, we have to attain immunohomeostasis. How? We still don't know. Probably steroids in the right dose is what we are learning about. How well other immunomodulators work, we still don't know. And we have no major clue about it. But this cytokine activation, obviously SIRS or CARS phase, both are dangerous and both have their own consequences.
Thank you, Dr. Yash. Dr. Jaju, would you kind of elaborate on this, your experience on the whole package where there is a single organ dysfunction leading to a kind of secondary infection, and finally the survivors who has to go through multiple obstacles and finally comes to a point where he comes out in that journey, getting cytokine activation syndrome, getting chronic critical illnesses or critical illness neuromyopathy, and having nutritional kind of or what is called loss of muscle mass. So any take on that? Just a kind of commentary or any notes on that, Dr. Jaju?
I think being a critical care specialist, we are more concerned about the patient when they are in the ICU. I think COVID has taught us we have to go beyond the four walls of ICU. What happens to the patient? I think that's the lesson we learned. And when we follow up the patient post-discharge from the intensive care unit, we get a lot of inputs from the patients and family, what we should do in the various terms about the interventions, medications, the counseling, the positions, so on and so forth. My experience about these patients, when they get discharged from the ICU, just I'll take 1 minute extra. Most of the patients, what we follow up in the post-discharge, most of the patients, nutritionally, they're very poor. They are not given adequate nutrition. Nobody gives counseling for them what to give the feeds. Mostly they continue only milk or something, soups or waters. That is not sufficient. They come with a thick, only bone and severely malnourished they come. Mostly they do physiotherapy. They developed about, most of the patients, they develop the various bed sores, pressure sores, getting infected and complicated. We see most of the patients we send with the tracheostomy because of the various reasons. Tracheostomies get full of muck, secretions, and most of the times it get blocked. That's what our experience is there for post-COVID patient what we discharge. I think is a reopener for all the critical care persons. The reason the intensive care not inside the four walls of the ICU, but you should extend beyond the four walls of ICU and even after the discharge for the patient also. I think that is a true intensive care doing it. In further extension to this, what approach we follow at our place, once this patient recovered and patient requiring some form of support, is important for the patient to requiring oxygen, requiring nutrition support, everything. What we follow the protocol is there. We have the psychologist, we should counsel to the patient and family. They'll counsel to the patient what we expect from the family or the doctors, up to what limit. and the counsel to the patient also what is expected from him, what to do, what not to do. Because there is the mismatch happens about the expectations of the patients and family. They want patient to become all right and run, but that is not possible. The reason we involve the psychologist or the social worker who have been trained particularly for the intensive care unit. As we are training for the organ transplant, the same way we try to train the people for the intensive care unit only. That is one part. Second part, we tell them about the occupational therapist, OT/PT. According to their disability, we try to make them to do the activities. Third, very important role about the nutrition. It requires the combinations of both the formula feeds and kitchen feeds, and particularly the dietitians who have been trained for the medical thing is very important. And the fourth is important about doing their physiotherapy and keeping a long term in the rehab centers. And we've seen the patients after 3 months or 6 months down the line, they're completely coming back to the routine work. That's what our experience is about all the post-COVID patients for the rehabilitations and care.
Thank you, Dr. Madhusudan. I think it was wonderful. Now, in the interest of time, we have to wrap up, and now I'll just request Dr. Chandrashish to give his thought on how can we prevent and create awareness for this, the biggest killer or the silent killer, sepsis. What is your thought on that, and your some opinion about the antimicrobial stewardship programs and more of awareness?
How to create awareness? I think there are various forums which have been made. ISF is one, and there are many more who are creating a lot of awareness, which is a great thing. We need to definitely create awareness not only among healthcare individuals, but among common men. How to reach there, how to reach people who are at high risk of mortality from sepsis is something that we need to think about. These will be elderly individuals, immunocompromised individuals, CKDs, heart failure patients, immunosuppressed, cancer patients. They have a very high incidence of mortality from sepsis, particularly, and they sometimes do not realize that they are becoming septic and they land up to the hospital late. So this is something where we need to work. We need to work on early diagnostic objective tests which will help us to identify sepsis early. This is the area of research which definitely is developing, but it needs to develop furthermore, so that because sepsis still now has largely, the diagnosis of sepsis is largely clinical. We have to identify organ dysfunction and identify that there is an organ which is infected, and then we come to the diagnosis of sepsis. But we don't have something like your let's say an NT-proBNP where we can say NT-proBNP is high, okay, so maybe the patient is likely heart failure. We need something like that.
Correct.
So
yeah. Thank you, Dr. Chakrabarty. So Dr. Yash, one line, you have been very active. You are at the forefront of spreading awareness, but are there real public initiatives where the public awareness can increase, and how can we all come together?
Last 6 to 7 years in India and 10 to 12 years globally have been a sea change in sepsis awareness. But still, as Chandrashish pointed out, we have to catch them early. We have to catch them in the community. We were discussing in another forum that still there is no literature about sepsis onset from the community. And we are not talking about community care bundles to prevent sepsis, basic interventions like hand hygiene and proper stool disposition are still a major issue in major parts of country. So we have to have a multi-pronged approach, and what we do good is institutional approach we are good at, but we have to generate a lot of crosstalk not only amongst non-intensivists but also amongst GPs, community health workers, and we have to increase awareness in the community and the policy makers as well.
Thank you. Dr. Sanjeev, one quick closure and then we'll hand over the session.
Yeah, so teaching is not a lost art, but the regard for it is a lost tradition, is what I feel. Education is not the filling of a pot, but the lighting of a fire. So I think we should take the mountain to the Muhammad. We should actually get all this sepsis thing to the masses through starting from us, starting from the third MBBS, medical officers, PSM. From there, we should start it off in a very, very big way, and then take the political scenario by storm. This is how it should be done, because it should go from the grassroots towards the top.
So thank you all my fellow panelists. It was wonderful interacting with all of you. I think we have completed our hour, and I would hand it over to the ISW. And thank you very much once more. Highest regards for this platform. Thank you.
Thanks to all the panelists. Thank you very much.
Thank you very much.
Thank you. Bye-bye.
Thank you so much, Dr. Ansari, for conducting this session. And yes, awareness is very important for people to understand the importance of sepsis and the effect it has on people, their lives, the deaths that take place, and which can be prevented. And this is the attempt that we are trying to do to increase awareness about sepsis. Now, the COVID-19 pandemic has exacted a heavy toll on mankind, with 4.6 million deaths already reported worldwide. Now, on the flip side, perhaps the only benefit that has come out of this experience from the pandemic is the focus on self-help, prevention, and hygiene. By following COVID-appropriate behavior of social distancing, avoiding crowds, wearing masks, and frequent washing of hands, a large part of the population has been able to stave off routine infections like flu, stomach or urine infections. But is this a big achievement? We all thrived despite these infections in the pre-COVID era. Yes, it is, because even a small unattended wound or a routine bout of flu or an infection can lead you to sepsis, a life-threatening condition. So if you cut the root by better hygiene, could you reduce the risk of sepsis? To discuss this, we are now joined by an eminent panel of experts. Please welcome our experts who are joining us now. We have Dr. Harish Malapuram Maheshwarappa. He's consultant, critical care, Mazumdar Shaw Medical Center, Bangalore. We have Dr. Prashant Saxena, Associate Director, Critical Care Head, Pulmonology and Sleep Medicine, Max Hospital, New Delhi, and Dr. Venkat Raman Bola, Clinical Director, Department of Critical Care, Jehoda Hospital, Secunderabad. So, a big welcome to Dr. Prashant and Dr. Harish who joined us. And I think Mr. Venkat Raman is on call. Yes, thank you so much to all of you for joining us. Now, sepsis kills one person every 3 seconds, and 213 per 100,000 people in India. India has the second highest sepsis death rate in South Asia. Now, post-COVID, people have been more careful about washing hands and using sanitizers. So, Dr. Harish, in your practice, what did you see? Have you seen lower number of sepsis cases?
Good evening, all. So, on this World Sepsis Day, so I'll wish everyone to be safe with avoiding all these infections which created a problem in the last 2 years. So, for your question, so definitely answer is yes, but it is too early to tell anything, because there are 2 ways we need to think. So, one is the behavior what we adhere to practice in terms of like preventing the spreading, so particularly hand hygiene and like avoiding the crowd gathering and all. So along with that, one important aspect which we introduced in the management of this pandemic is wearing the mask. So that is absolutely true, because our major burden of infection when it comes to any tertiary care intensive care unit, so we have in and around respiratory tract infection. It's not only the COVID, so we have other communicable like respiratory illnesses both in adults, in susceptible population, particularly immunocompromised patients, those who are on steroids, or elderly, or in the pediatric age group. So this behavior what we adopted in the COVID definitely is going to help in big way. But the therapies when it comes to COVID and all, like if you consider that also as one of the behavior what we done on the aspect of therapies, like we used some sort of immunomodulating agents, steroids and all, which make some percentage of the patients more susceptible to catch up some secondary infection which landed them with a sepsis, secondary bacterial infection and all those things. But first, like if you think like whatever we adopted in the management of COVID as a COVID appropriate behavior, definitely, which is going to help in cut down the spread of infection. So which is going to cut down the spread of the chain of infection and all. Absolutely.
All right. So that remains a heartening thing that this sheer better hygiene will help us more. Dr. Prashant, what have you seen in your practice over the last year? Why I'm asking is because AIMS has done a study, and during the second wave, they found that patients who were lower than 50 years, of all those who were admitted to the ICUs, there was a large number of people who died because, so on one point, we have better hygiene, and we are staving off the routine infections. Then we have this serious COVID infection, and what we are seeing in patients is something very similar to sepsis, multi-organ failure. And we didn't understand the disease early on. We were using antivirals, and now we're seeing that something else is at play. What Dr. Hari said, immunomodulation is perhaps going to work better. But in your experience, have you seen a rise in the number of sepsis cases over the last 2 years or 4?
See, I think it's a changing scenario which we are facing now. We are facing an epidemic over the last 2 years. So I don't think it would be wise to compare these 2 years with the pre-existing, incidence and prevalence of sepsis. Because sepsis has been the major cause of morbidity and mortality across the globe, not only in the Indian ICUs, but across all the ICUs of the world. So sepsis is not a new thing. Sepsis is something which is pretty much in, and every day we see deaths related to infections and sepsis. I agree with Dr. Harish that the heightened use of immunosuppressive medicines, including steroids, has led to a rise in post-COVID infections in the society, not only bacterial, but also infections of fungal and other origins, including tuberculosis. So we have seen definitely a higher incidence and prevalence of sepsis. The other reasons why I feel sepsis was high, because there was a lot of patients inside the hospitals. Our manpower was compromised. Our infection control practices were compromised. And there are so many things. The people were not being audited, and it was like every hospital was flooded with patients. So definitely there were breaches. There we have to accept it's a hard fact, but I have to say this. There were some challenges which we faced, all of us faced, including lack of, essential medicines, oxygen, and all those things were there. So definitely, there were cases of new onset sepsis and infections, which I saw a lot of cases. Definitely, they went up, but there was a reason for it. It was not particularly related to COVID, because viral infections have been there in the society for long. COVID is also one such infection. It is because the epidemic, a lot of patients coming in a short span of time, flooding the ICUs, manpower compromises, all these things, and including the immunosuppressive agents, irrational use of antibiotics, all these things contributed to the heightened incidence of sepsis, what we saw.
Okay, so on one side, you're making gains on better hygiene, but in the pandemic, I take your point, it's not fair to compare sepsis during the pandemic and in the previous years when life was normal. Dr. Venkatraman, I request you to unmute yourself and tell us what has been your experience over the last 2 years when it comes to sepsis. I know hospitals were engulfed with COVID patients. What did you see in your ICUs when it came to sepsis?
See, honestly speaking, initially when we saw many of our healthcare professionals are geared with so many hand hygiene policies to start with, and then they go with the PPEs covering from head to toe, wearing many layers of gloves, we thought the chances of nosocomial infections would go down. So contrary to many of our initial assessment, it went just opposite to it. To be honest to you, initially when we were actually ventilating and managing around 500 to 600 ICU patients, as rightly pointed out during that pandemic, with around 1,500 I have all over 3 hospital patients, we have definitely seen a surge in particularly gram-negative septicemia, followed by some fungemias. I felt already pointed out 2-3 reasons is one is manpower, and as Hari said, there were many other challenges during this pandemic. What I felt was hand hygiene has gone into a tussle. See, many people felt wearing a glove is everything done. Changing the gloves between patient contact was a big challenge. You needed almost a huge set of gloves to change in between every patient contact. So what happened, and rubbing hand rubs during in between the patients, in between the activity was also gone into tussle. So what we realized, the nurses, the healthcare professional who weared a glove, they felt they had enough protection for the patient or for them. There, probably the hand practice or hand rub practice or hand sanitization practice has gone into a tussle. That's what I felt one of the reasons. The second problem which I felt happened during this COVID pandemic is, see, we had around 500-600 patients. Among them, 150 or 130 patients were in ICU. And among them, almost 100 patients were in invasive lines and arterial catheters and CVC catheter. If I look at out of 500, if my 400 or 380 patients were non-invasively managed without a tube, without a line, then I have seen almost normal infection rate like any other patients. I have not seen any increase in gram-negative infections in them. When I don't have a CVC line, I don't have an arterial line in place, if I don't have an endotracheal tube in place, I have seen the same number of infection what I have seen with a normal population. The moment I invade the patient with a CVC line, arterial line, or a tube in trachea, I have seen somewhere we staggering around a gram-negative bacteremia, which is the leading, followed by some of them as candidemia when they received either a tocilizumab, infliximab, or other immunomodulators, and a steroid in a higher dose and transferred to us in a later part. So I believe it is multifactorial. Even though we believe all healthcare workers were covering themselves from head to toe, but the hand hygiene has gone into serious tussle. We have done a surveillance. We have seen the number of opportunity to do a glove change, number of opportunity to do a hand rub, hand sanitization has almost dropped to 1/10 what they normally used to do. And the glove change, when we said you have to change the glove, they required almost 10-15 times the number of gloves they required to change over. And some of our microbiologists also recommended to rub the hands over the gloves with hand sanitizer. It was very sticky. I practically did it. I saw it was not possible. It got into stickiness because chlorhexidine and alcohol on a glove don't work.
All right, so these are real everyday living problems that our healthcare professionals have gone through. But this has been at a time when we had first or the second wave where we had a huge swath of COVID patients coming in. And I'm sure our healthcare professionals are very smart and they learn on the job and they will find solutions to overcome these issues where what you have spoken about hand hygiene is something that we'll go back to the best practices possible. Now, what I want to try to understand is, Dr. Prashant, I come to you. Now, in India, we're still very strict, but abroad we have seen many governments remove the mask mandate and say that, okay, you got vaccinated, so you can get rid of your mask. Now, we're seeing what is happening in some of the countries is that there has been a surge in COVID cases again. And we may even see more of bacterial respiratory diseases. So if masks are off, would you think that the risk of sepsis is also on the rise?
So, see, initially when there was a lot of enthusiasm about the vaccines and the subsequent vaccine-related immunity, the enthusiasm grew so much that even the US president asked his countrymen to remove the mask. But then they gradually understood that without the mask and in a vaccinated individual, you still have asymptomatic infections, which means infections where the patient will be asymptomatic due to the vaccine immunity, but this person can transmit the disease to other persons. So being vaccinated doesn't mean that you cannot transmit the disease. You have a risk of less serious illness, you have a less risk of admission to the hospital, but that does not guarantee the other individual's safety. So mask is mandatory because asymptomatic infections do happen. You cannot shy away from not wearing a mask, and all the COVID appropriate behavior has to be followed. We have learned this again and again. So this is in our books now. This will not be history. And
Dr.
Prashant,
what I wanted to know was that, do you think you're talking about COVID, keeping the mask on despite vaccination. I'm seeing other diseases, other viral and bacterial diseases. Do you think that, it should not be a diktat, but people should willingly wear masks to stave off the other things as well? Does it really effectively work? What is your view there?
Yeah, see, I have personally seen that most of the patients who had, I manage a OPD also, along with managing an intensive care unit. Most of my patients and most of the sufferers, they were all those who were not following the COVID appropriate behavior and the hygiene and the simple rules of, any infection. And, COVID has taught us a very good lesson that we have to be abiding by the rules of hygiene and health in the society from now on. You cannot survive. See, flu has been there for decades. Swine flu, bird flu, this flu, so many varieties of flu happen every year, but we hardly care. But this became a killer. So then everybody woke up. So now the time is there where we should not be, suddenly becoming, biased towards the mask. It is something which is going to help us. I understand you cannot wear 24/7 mask, but wherever required, wherever you are in touch with the public, or in crowded populations and meetings, it is mandatory. Even if two vaccinated individuals are sitting, it has to be worn.
All right, Dr. Harish, what's your view here? Now, Dr. Prashant feels that keeping mask on in high-risk positions in a crowded market, in an indoor setting where it's crowded, you put your mask on. But do you think if you keep washing your hands and do not wear your mask, it will suffice? Because, washing your hands will not just help stave off COVID, but also other, stomach flus, and so many other diseases that in India, because of the lack of sanitation facilities, these infections are very common. So what do you think? Because, like Dr. Prashant also said that, you can't keep a mask on all the time. But what should be the best practice for people who want to take care of their health?
Basically, we are roaming around here something called transmission specific prevention and all. So we have like contact oriented organisms. So definitely the hand hygiene is going to be some sort of universal precaution. So we have the bacteria, like the gram-negative bacteria, which can transfer from one person to other person in the healthcare setup. So I'm not speaking in the community kind of this one. So in and around the ICU, in and around the recovery, in and around the high dependency units and all. So basically, if you done the hand hygiene, definitely it is going to prevent contact related spread of infection. So we have something called resistant organisms like MRSA, VRE. So multi-drug resistant gram-negative organisms. This is a huge burden. So which is, we can tell in terms of outcome, which is more dangerous than that of the COVID outcome, definitely. Okay. So if we done the proper hand hygiene, it is not like, as Dr. Venkat clearly told, means it is not like, so we are just wearing the gloves. It doesn't mean we are not going to carry the infection from one person to other person. That is a myth. Okay. So we need to change the gloves and we need to do the hand hygiene. We have specifically something called 5 movement of hand hygiene and all, which is been WHO prescribed in and around the healthcare system and all. So in the community, definitely, suppose if you come from any area, you done some sort of the public transport, you felt like you touched here and there and all, it's a good practice to do the hand hygiene and all. So definitely it will help, no doubt on that. Okay. So on the other hand, when we club hand hygiene with that of the mask, that behavior definitely is going to prevent other mode of spread. We have something called droplet mode of infection spreads, which is not only for COVID, we have other viruses and the bacteria also. We have some couple of atypical organisms, atypical community acquired pneumonia organisms like chlamydia, mycoplasma pneumonia. So these are the atypical organisms. Most of the time we are not going to isolate all these organisms, but with any particular test and all, because we empirically cover these atypical organism with some sort of the antibiotics. So when we suspect some sort of the community acquired bacterial infection, so these can be prevented by some sort of the droplet precaution, which involve wearing a mask also. May not be an N95 mask, so appropriate keeping the distance, appropriately using the mask and all. So even if it is not an N95 also. So along with that, we have a burden of other viruses, tuberculosis. Even though tuberculosis, we know that we need a proper like N95 mask and some sort of in hospital area we need a negative isolation and all. See, some barrier definitely is going to prevent the spread of infection from one person to other person and all. So when you ask me which scenario we need to like use all these hand hygiene and that of the mask, as much as possible. Okay, so you define yourself as much as possible. You have to define. Okay, you are going to crowded area, you are going to like shop, you are going to medical store. Okay, you are going to like visit any of the patient who is staying in the hospital just to say hi to him. So definitely all these things like help. So we need to have that culture. Okay, so we might not able to do some sort of comparative randomized control trial, so what is going to happen and all, but I feel it's a common sense. Okay, so even though which might add some additional burden of the economy. Okay, so maybe frequency of changing the mask, but in an appropriate way. So in an appropriate way. So if you tag like, okay, hand hygiene kind of this one, so we are just wearing the gloves. Okay, we touch here and there and we carry the organism from one person to other person. It's not going to be like that.
So, Dr. Harish, you're talking of a clinical setting. I'm talking of the community setting.
Yeah.
For the community at large, what works better? Is it mask or is it
again, I told like we have to club as much as possible. Okay. Suppose
combine both.
Means like you come from an like public movement and public transport and all, you wash your hand and wear the mask when you are moving in and around in the public area and all. So as much as possible. See, you assume you are safe, you are isolated, nobody is there. Okay, you are not touching here and there where most of the public movements happen. So then you avoid it. So you have to decide as an individual what is your risk profile. Okay, what way you are daily moving in and around kind of this one. So suppose if you tell only when you go to marriage you wear the mask, so then what about the office? Okay, what about like going to a bank and all? So you have to define your own way. So where is the risk profile and where is the risk movement and all?
Dr. Venkatraman, what is the role of good and consistent hygiene? Like Dr. Harish has spoken about, Dr. Prashant is saying, you find your the way you want to work it out, but you have to keep washing your hands. You have to, wear a mask in public. And this is to stave off regular infections. How effective do you think this is going to be? And how difficult it is to get that consistency in maintaining the hand hygiene? Because we tend to get complacent. अब तो हमारे शहर में कोविड खत्म हो गया, अब ठीक है. Like in the first wave, when the vegetables used to come, you used to scrub them, wash them, lay them in the sun, wash your hands. Once they're dry, get them back. So now we are a little more, we understand better. So we are a little more at ease. But what are things that we can't let our guards down, and how do we get the consistency in doing this on a community level?
So I think we are discussing about two components. One, we are talking about COVID appropriate behavior, which we all understand now across. And the other one, you're talking about universal standard hygiene practices, which we all should be practicing across the times, whether it is COVID time, swine flu time, enteric fever time, or any of the time. See, if you look at the initial part of this pandemic in 2019, December to up to maybe April, May, lot of importance has been given to fomites. See, they said it is more of the fomites through which transmission happen. It's not airborne. The droplet burn also gets a secondary handout, but most of it has been more fomites generated when you touch the surfaces which has been inoculated by this virus, and then you come in contact with air and mouth and nose, and that's how the virus can be transmitted. Over a time, if you see over the last 1 year or more than a year of time, there have been many studies. Even this virus may survive in many of the surfaces. The fomites related hand-based transmission has been taken into a second layer. If you see, the more of the it has been gone into how do you wear a proper mask. See, again, I will just talk about the other side of the things. See, if you see, there is a surge in fungal infections right now in India after a COVID. There were many other co-related infections which can be caused by the mask, which we have to understand. See, if you see a mask which my maid wears or my security wears, look at those masks. Please, if you have a time, just look at those masks. This mask has been worn for more than a month. not washed once, not been dried once, not been taken care of that, and you are just breathing those masks on your face continuously 15-20 times a minute. So there are collateral damages with this mask. So what I mean to say is, see, we need COVID appropriate behavior in and around the COVID time, which may be another 2 years or 3 years, where masks will be one of the priorities. And we, at this point of time, you said few of the countries have started lifting this mask, but India cannot afford that at this point of time. Our immunization has not gone to that extent. And we are also seeing there is a immune escape to this immunization also. So masks will be an integral part of COVID appropriate behavior, at least in India at this point of time. I don't think we can afford to withdraw masks from us. Coming to the other hand hygiene policies, which we are talking about in general in community, not in the hospital setups. See, what I believe is this should be an integral part of all our behaviors. See, you talk about our worm related infections. You talk about any either enteric gut related infections. You talk about any other viral or bacterial infection which gets transmitted by hand hygiene practices. These should be an integral part of our primary school, secondary school, and it is integral part of our healthcare behavior or your normal family behavior. Like any other, like you say, you behave well with other families when they come, you behave well with the guests. So your hand hygiene, the general standard hygiene practices should be appropriately groomed up in our kids and our families. See, when you go for a lunch or dinner, you wash your hands. When you go for your restroom, you wash your hands. In the same way, when you go outside, you make sure that you make your hand hygiene a standard practice. That should be a long way to go, and those should be an integral part. Whether mask will be an integral part forever, this COVID has been definitely a game changer. We don't know how many years it will be, but at this point of time, talking about other viral, other bacterial, and other infection which can get transmitted through a aerosol or a airborne, to prevent them, wearing a mask as a standard, probably I have my reservation for that, but hand hygiene should be a standard practice.
Okay, and in medical settings, would you
in
think that
the changes which we have done in our medical settings, if you see the early part of this pandemic in and around the first wave, see the N95 mask was in high demand. If you see, most of our doctors were not ready to wear a surgical mask, a regular mask, even out of the hospital setting, even a cloth mask was not a common practice. So there were many debates. CDC never allowed a cloth mask, if you remember. It was not a part of. See, later on, the same WHO CDC said, yes, a well-dried, clean, hygienic cloth mask do well. And initially there was no concept of double mask. Now we are saying the outer mask can be a disposable one, which we can actually discard. The inner mask can be reusable mask, which we can continue use. The changes which we made in healthcare setups is, from the initial part of that panicness with that apprehension of transmission, many of our healthcare professionals demanded for a N95 mask in non-ICU settings, even in non-aerosol generating times. But now we have slowly moved from that to a setup where many of our clinicians are accepting a regular standard surgical mask in non-ICU setups or in non-aerosol generating procedures. Whereas in intensive care unit, where we are in contact with aerosols, we are requesting for either a N95 or a respirator in any form.
Okay. So we have some guidelines to work on. Now, because of COVID-19, there's a lot of focus on vaccination as well. Now, when it comes to childhood immunization, there is a proper program, and most parents will follow the mandatory childhood vaccination program. There are, of course, many optional vaccines that can be taken in childhood and adulthood. Dr. Harish, do you think vaccination is something that everybody should now focus on, not just for COVID, which is a pandemic now, so everybody who's eligible should take it at the earliest possible date, but for other preventable diseases where there is a vaccine, people should start taking them? Does that also help prevent sepsis?
Yes, definitely that is going to be the way, like not only for the COVID, we have some other viruses which have some seasonal breaks like flu and all those things. We used to have a particular strain of the flu. We are going to have the flu shots and all. So as a part and parcel of yearly vaccination. So that should be adopted, particularly for all like susceptible population, even not only pediatric, in adults. I feel those who work in the healthcare setup, elderly and all, because that is one thing we need to concentrate. And other vaccines, like we have some encapsulated organism like vaccines like pneumococcal vaccine, okay, meningococcal vaccine and all. So in a susceptible population, like particularly elderly and all, so those who had some sort of recent hospital admission and they got discharged, these kind of vaccines also we need to concentrate, not only just the COVID vaccination, not only the vaccinations which are involved in the vaccination program and all. So that helps in cutting down the incidence of the sepsis, because when a person is having some sort of influenza H1N1, so there are lots of literature available. They are more susceptible to have bacterial infection, that is MRSA, that is the Staph aureus pneumonia and all. So they are more susceptible to have some sort of the invasive fungal infection. So there is something called molecular mimicry. So there are some literature published on all these things. So definitely, if you practice not only the vaccination which we have like drive, so optional vaccines also we have to think now onwards to prevent the onset of the sepsis as a major burden in the hospital scenario and all.
Dr. Harish, for adults, what would be the vaccines which are optional, which you think that everybody should consider taking?
Yeah, that's right. So once we are maybe weaned off from this COVID, or maybe in between when we have some sort of like no much incidents and all. So when the movement started happening, so one is the flu vaccine, so seasonal flu vaccine. So whatever the strain which is available in the like particular healthcare setup, and in a susceptible population, pneumococcal vaccination, so influenza vaccination, Haemophilus influenza vaccination and all. So these 2-3 things we need to concentrate. So one is meningococcal, so that is in a susceptible population and all. So these 2-3 vaccinations we need to concentrate.
All right. And what do you think, Dr. Venkatraman, do you think vaccination has a role to play to reduce the incidence of sepsis? Because, people think sepsis is a consequence of a disease. Nobody, search the map and look at where it came from. It was bad luck. You had an infection and you got sepsis and you didn't get to the hospital in time, you didn't get good care and you succumbed. They don't, draw the roots of it. You think it is bad luck. What do you think? Should you risk bad luck or should you take all measures, including vaccination?
See, we do understand there are multiple components for sepsis to happen. It's not just an infectious agent, as you also had some pointing out for that. As we all know, there is a host response involved in that, and it varies. It definitely varies. So yes, some amount of host is also responsible, how an individual host responds to that virus. So there may be a component of whether you say it is a luck or a dysregulated response. But yes, the initial insult will be from a infectious agent. So right now, if you look at our admissions, even in our hospital, we have seen a surge of influenza. We are seeing almost every 4th or 5th respiratory admission is being influenza, and some of us being an also atypicals. So why it is happening is because in the era of COVID, all the other diseases has taken a backseat. If you look at pediatric vaccination, as pointed out by Harish, also the vaccination of pneumococcal, meningococcal to the high risk population, all has taken a backseat because many of these high risk population are not coming out of their house in fear of getting exposed to hospitals and this COVID. So this has also been a reason why the vaccines has taken a backseat. The pediatric population has a big list. Many of them has missed their vaccines in the last year, and many of them also missed influenza for the last 2-3 years. So I agree with Dr. Harish that vaccines now, at least at this point of time where COVID number has gone down, hospitals are opened up, non-COVID areas are fully available in many majority of the hospitals. Pediatric population should be fully vaccinated as for their schedule. Whatever the missed vaccines should be taken care. And for adults, influenza and pneumococcal and meningococcal in a high risk group, and influenza for almost all individuals are the requirement. Now we are seeing some other surge also, like dengue. See, I'm not sure whether Haris is saying the same trend in Bangalore. Almost our 30 to 40% our hospitalized patients being dengue. It's we unfortunately don't have a vaccine for it, but same precautions to dengue. Any fever, it is may not be a COVID now. If I have a fever, I have a more chance that now at this point of time in Hyderabad, it is related to dengue. So we need to keep a follow up on monthly CBC and a platelet rather than a pulse oximeter or a respiratory distress in them. So I will like to just point out or summarize in this way ki in the era of dengue, we forgot all the other common diseases which were happening. I think it is high time where we need to focus back on all those vaccines and also the other common diseases which are happening and their preventive measures, including vaccination.
Right. Dr. Harish, vaccination, of course, has its role to play, but vector-borne diseases are not really related to hand hygiene as such. It is related to environmental hygiene. Now, my question is that, since these are also vector-borne disease, also endemic in our country, malaria, dengue, after monsoon, it happens. Now, when should people realize that this is not normal, Dr. Harish? When should they, what are the signs to watch out for? When should they approach their doctors and ask for help? What is the risk that they get sepsis because of that?
So basically, what we have, this COVID manifestation is, unfortunately, it is some sort of very non-specific. Okay, you can have the fever, some sort of body ache, or general myalgia. So all these things are prodrome for some sort of the tropical infections which spread by vector-borne like root and all. So high-grade fever which is not settling. So then like some manifestation with a severe like myalgia, which is not so common with COVID, so which is more towards like dengue, like backbone fever, what we cause, are like rapid progression. So they are saturating well. So rapid progression in terms of high grade fever, so severe dehydration, so that move towards like dengue with a loss of body water and all. So are complicated malaria. So if they have some sort of cerebral malaria manifestation or bleeding manifestation. So usually platelets we saw in the COVID infections and all not so badly dropping and all. So tropical infections which are vector borne, so they are more towards having a drop in the platelet. If they have some sort of petechiae like skin manifestation or some infections, we have some typical eschar formation in the hidden areas like scrub typhus and other infections and all. So other clinical manifestation we have to be alert is like encephalopathy. If they have fever and started having some sort of altered behavior and all, so then we need to focus, okay, it may be in and around like vector borne kind of this one. But initial when they have a subtle manifestation, so it is a bit tricky, but we have to think always out of the box, because so as Dr. Venkat told, like in Bangalore currently we don't have such an incidence of like dengue which is increasing and all. We are having a separate problem like those who are like chronically having problem with the COPD, asthma, so they are getting exaggerated, so they are like getting admitted kind of this one. So
and
we had
these are the patients who had COVID. Is that correlation?
No, may not be COVID. So they stayed in home because of the worry of the COVID till now. Okay, so now they started socializing. So they started coming in and around kind of this one. So then they have their own exacerbation. So they are all chronic illnesses. So like that we are getting. So not typically we are having a high incidence of particular vector-borne or tropical infection. Maybe it is dengue, malaria and all. Maybe there might be like 15 to 20 days or 1 month drag kind of this one. So basically we are not so far from Hyderabad and all. It may be a trend in Bangalore also. But for your question, it's a bit tricky. So other than like when a patient is having a more advanced manifestation, we can narrow down to some sort of, we have something called syndromic approach kind of this one. But these dengue can also cause some respiratory problem. Like we have that something called ARDS, which is a manifestation of the COVID also. But so-called happy hypoxia, okay, they look all right. When you measure their oxygen, it is low. So that might not be a scenario when it comes to this vector-borne like lung manifestation and all. So they can have immediately a pulmonary hemorrhage if the platelet is low. They can have the bleeding in the lung kind of this one. So all this bit specific more towards the tropical infection as a blanket approach we can consider.
So, Dr. Harish, you spoke about chronic diseases and how some of the chronic diseases may flare up now that people have started socializing, etc. So, would these people benefit by better hygiene, washing their hands, keeping their distance? Would they also benefit in the chronic condition?
Yeah, obviously, because as we discussed, like it is not only for susceptible, so non-susceptible also good hand hygiene practices are going to help. So all these chronic diseases, when we call them as like COPD or like chronic obstructive pulmonary disease or some sort of asthma and all, so they will be on in and around some therapy called steroids and all. So they will be having some sort of structural changes in their respiratory tract and all. So when we allow them like openly kind of this one, they are susceptible to all these community acquired infections and all. So other chronic diseases like diabetes is a chronic disease. So uncontrolled hypertension is a chronic disease. When the patient is having an uncontrolled diabetes as a part and parcel of their chronic disease, or maybe some connective tissue disorders. If a patient is having a rheumatoid arthritis, so they will be on some immunomodulating therapy and all. So they will be on some sort of steroids and all. So obviously, when they have like inappropriate practices of moving without any extra precaution and all, so they are like susceptible in this era also, otherwise also.
All right. So we've spoken about vector-borne diseases and we've spoken about chronic diseases. Dr. Venkatraman, you said that during COVID pressure, the hand hygiene amongst medical professionals wasn't the best possible because of the sheer pressure that existed. Have we gone back to normal? And because of this realization that hand hygiene is very important, have we now set a new precedent that at least in hospital settings we will try to avoid the spread of these very scary bacteria, the drug-resistant bacteria, the hospital-acquired infections that people dread, when they go for surgeries, because of this heightened realization of hand hygiene? Would we be in a better position to stave all these off?
Yeah, true. Actually, when we actually analyzed the data of the COVID intensive care unit in the different waves and that peak season, we realized definitely the hand hygiene. See, the first important thing is that false confidence or that false impression that I have a glove on my hand, so it protects infection. In fact, what I felt is the gloves was the main reason for the spread of infection. One single glove for a multiple purpose, and that spreading infection from one point of contact to the multiple sites, and probably that was the one of the important reasons. So the changes we made is in non-COVID ICU, no gloves except when it is indicated. So we again gone back to the same standard old practice like hand washing before entering to a patient and in between patients, and hand rub in between, as he said, the multiple patient contact points. And whenever they are handling any sterile places like a saline, drug infusion or a body fluids, a clean glove, and that glove should be weared and taken off in the immediate way, and again go back to hand hygiene and with all the steps. And we have seen a drastic drop of infection rates to the pre-COVID era. And we have realized we told, this has been an example, we told to all of our healthcare professionals, see, just wearing a glove will not make your patient safe. You need to understand that gloves should be weared in a proper indication, should be changed in between in the situation like COVID, and probably the hand hygiene cannot be taken as an alternative way as a glove, wearing a glove in those situations. So you rightly pointed out in post-COVID, we have back to our old practices, and we have seen a drastic drop in number of infection in our medical ICUs. It is not the same what we have seen in COVID, but we have to see if we have another wave of COVID, what will happen with again gloves on. We have not yet gone to that phase.
All right. Dr. Venkat, I think it was you who mentioned that of all your COVID patients in ICUs who were intubated or who had invasive treatments undergoing, it had bad prognosis. So could you tell us, is there any connection here with hand hygiene? Because, I mean, does the intubation or, putting a syringe or anywhere there also, the risk exists to, introduce infections if hands were not cleaned properly?
Yeah, see, what I actually realized is if my patient is not having any invasive device, whether even though they are a COVID patients, even though they are receiving a moderate to low dose of steroids, even though they received some immunomodulator, the risk of they getting a bacteremia, the risk of they getting a secondary VAP was extremely low. It was almost like same to our non-COVID patient. There was no much change in them. But when we came to the intensive care areas where the patient was intubated, not even on NIV, if the patient gets intubated, patient got a central line, patient get a dicath, patient get an arterial line, we have seen a surge of first GNB, gram-negative bacteria, which has been common with in VAP, also with the central lines. The common bacteria were same like a Klebsiella pneumonia, which was common in our medical ICU, some of the Acinetobacter, some of the Pseudomonas, and some of these patients, when they receive some form of polymyxin or colistin to cover these XDR pathogens, they grow some escape pathogen. So what I felt is, in these patients, when there is a endotracheal tube in place, central line in place, arterial line in place, many of our nurses used to handle them with the gloves. And as we all discussed, the nursing ratio in those peak seasons was relatively patient to nurse ratios were extremely low. And there were the practices, the bundle practices like oral hygiene, subglottic suction, cuff pressure manometer, elevated head end, all these were extremely gone into a tussle. Central line maintenance also, I don't believe the insertion was a problem, because most of the insertion happened by the intensive care team. It was done in the same aseptic surgical way, but the maintenance was a tussle. The multiple infusions, the same nurse taking care of 3-4 patients, and there I think cross contamination, infusions with the same way, arterial sampling. What I've seen during this COVID is ABG samples. See, most of these patients were respiratorily compromised, so these patients needed a repeated ABG sampling. So the arterial line, when they actually remove the repeated sampling, if they don't keep that process aseptically handled, then you actually stain those transducers, stain those hubs with blood. And if you don't rub those hubs appropriately with alcohol solutions and flush them and keep the clean, then that can be a source. So handling of central lines, arterial lines, endotracheal tube was one of the reason. The second reason, which we already pointed out, the good amount of steroids were used in these patients, good amount of immunomodulators were used in this patient. And I also personally feel the COVID also hits our immunity. We all spoke about the helper T cell, the CD4, CD8 T cell. It definitely, in a situation of heavy cytokine storm where multi-organ involvement happens, florid sepsis happens, the immunity goes into a tussle along with this all. So that also, I personally feel it played a role to make these patients more susceptible to these bacteremias.
All right. I'm going to take some few last words. Dr. Harish, in your mind, going ahead, what is going to be the role of hand hygiene on a community basis, in a medical setting? How are we going to go ahead so that we reduce the risk of sepsis?
So hand hygiene, do it properly in a mandatory way whenever needed. But again, I am telling, do it properly. So like we are wearing the gloves, we assume, okay, so we are protected, but that is not the consensus. Like we go on touching, that is not appropriate. So change the gloves. This is in the healthcare setting. So whenever needed, before touching, after, we have a defined practice when we need to change the gloves and all. So that we need to practice. And when it comes to hand rub and all, so use it properly. So in the same way, in a defined manner in the healthcare setup and all. But when it comes to non-healthcare setup, so in the community and all, So definitely, like when you feel you have touched here and there where there was a like lots of public movement, so definitely need the need to practice the hand hygiene. So it should be a culture. So as we already discussed, so it should be a culture from like a pediatric age group to the adult to adolescents to that of the elderly population and all. See, that is a health good habit that is going to cut down all related contact related infections and all, no doubt. So that we need to incorporate so in our further practices, or maybe like education wherever we are going to speak in the maybe on a community based teaching, or maybe like educational institutes, or maybe healthcare setup. So everywhere that should be the mandatory in appropriate way, no doubt on that.
All right. So Dr. Harish has to have an important meeting, so he'll drop off. Thank you so much for joining us, Dr. Harish. Dr. Venkatraman, Dr. Harish is saying that you have to do this now. Hand washing, there's no negotiation. But how there has to be education and awareness. But do you think this fear of COVID has done a permanent reshift? Because people at one point we said that poor people do not even have access to water and soap. Where will they keep washing their hands? But then people point out that even when you had the access, even if you were in a 5-star hotel, you weren't washing your hands before going for a buffet. So is this fear going to change everything permanently? Or do we have to drilling down the message, wash your hands, wash your hands, wash your hands in public settings, take care and wear your mask? What do you think is going to work from here on?
Yeah, Anisha, if you look at the early part of this COVID, I think we were doing this all practices more like a OCD, obsessive compulsive personality
disorder.
So something like I felt it was overdone. I still remember the vegetables used to be kept in a bay with some kind of disinfectant for almost 5-6 hours. We used to keep all our parcels left there for 3-4 days. And I remember those early days where all our clothes were kept outside in a bin to a hot water dipped in and all that. But if you see over a time, in 1 year, slowly one after the other, we have landed up to a situation where we have seen the public, and even thus which you pointed out, the underprivileged and those who have access to everything, both have changed their mindset. And it is more of a behavioral issue. It's more of a attitude issue. It's more we have a cultural issue rather than just about availability, non-availability, and all. So these are the I think it should be a part integral. See, as we all know, wearing a seat belt, wearing a helmet. See, many of us when we start because there is a traffic policeman who may channelize us or who may penalize us because we are not wearing a seat belt or we are not wearing a helmet. But over a time, it becomes a part of your habit that the moment you sit on a car, you hold your back.
Put on a belt.
So I think that's what we are looking at. So at least this COVID pandemic has taught us that the healthy activity or the healthy kind of lifestyle, you need to be obese, or you should not be obese. You should be healthy. You should be out of comorbids, or you should be practicing this all healthy way of eating, healthy way of living, healthy way of gathering, healthy way of maybe hand hygiene, or some of the times maybe a mask. So I believe at least this has given a lesson to us that we all will start probably practicing them, and many of the common public is also. But I know if we don't re-emphasize it over a period, slowly over a time again the things will get diluted, and we again forget it back. So I think there is a solid reason to make these kind of practices inbuilt to be an integral part of our day-to-day activity and our habit, from our probably parents to kids to school teachers to government officials, that these are the common behaviors. I'm not sure about mask because it's not feasible, and some of the times this mask can, as I said, can be a have their collateral damage and can have a risk potentials if you do not maintain a mask hygiene properly. As I pointed out, if you just cross-check yourself. Many of those underprivileged, the masks are very, very soiled. They are dirty, they are soiled, they are using that mask for more than a month, not cleaning, not washing. They don't have money to buy masks every alternative day or once in a week. So these are the challenges. So maybe a proper cloth mask, 3 or 4, alternatively washing them, drying them, and they can be used them in a proper way, at least during this COVID time. Post-COVID time, general practices, including a general health hygiene, should be probably an integral part of our regular habits.
All right. Thank you so much, Dr. Venkatraman, for joining us and sharing with us your views, your experience on the treatment of sepsis during the time of this pandemic. Yes, like you said, that we may go back to pre-COVID days, but and this fear may wear off, but we need to build a habit, and that habit of hand washing will come if it is it's like a reminder. The habit comes if you see your parents do it. It becomes the norm to do, and all this will happen once we keep educating and keep reminding everyone. And this has been our effort to create awareness that even the simple act of hand hygiene and even the COVID appropriate behavior saves you from not only COVID but many other diseases that do have the risk of developing into sepsis, which is a lethal condition, and you don't want to be anywhere near that. So wash your hands often and save yourself. Thank you so much for joining us, Dr. Venkatraman. Would also like to thank the other doctors who joined us and shared with us their views, Dr. Harish and Dr. Prashant. So a big thank you to our experts for joining us and brainstorming on how to increase the awareness about sepsis. This show was supported by Bharat Serum and Vaccines. And do follow us on Facebook to get all the updates on our upcoming programs. Till we meet again, stay safe, stay healthy, and take care. Goodbye and see you soon.
Thank you.